Two, one, and we are live. Let's start.
Namaskar and good evening, everyone. I welcome you all for today's webinar on clinical management of common cancers, a newer perspective. And this webinar is going to happen in two parts, that is today and tomorrow, and then on 11th and 12th. And with immense pleasure, I would like to invite Dr. Tarachand Gupta, who is consultant medical oncologist at Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur, for the welcome and introductory note. Over to you, sir.
Thank you. Respected seniors and my friends, it's our great pleasure to warmly welcome you to be a part of virtual conference, Clinical Management of Common Cancers, Newer Perspective, 4th, 5th, 11th and 12th November 2022. The conference goal is to improve the knowledge and competence of cancer treatment, participants to apply practice-changing clinical data and expert recommendations to optimize clinical outcomes for patients receiving therapy in cancer. Experts are likely to help physicians and practitioners put the role of multiple therapies in a clinical context and discuss how they can effectively contribute to patient care. The treatment regimens on head and neck cancer, lung cancer, GI cancer, cancer, breast cancer, and ovarian cancer, which are most common cancer in the day-to-day practice, will be discussed. So we usually organize this type of conference in the year end so that we can summarize the till the date, whatever the updates are there in the oncology field. As we know, there are newer drugs are coming, or old drugs are coming with the new indication and improving the patient-related outcomes like overall survival, progression-free survival, and quality of life. So this usually helps the clinicians to make a summarize practice, and patients can get the benefit. So as we know that it was the time, go back time when if we recall the movie Anand, when the Rajesh Khanna died in 1 month after the diagnosing cancer, but it's now a rare thing. If the patient is getting treatment, it is hardly any patient who is going to die in 1 month. So now this is the actual scenario where the oncology stands now, and the patient's care improving and the survival improving. So now just be in time, and now I invite we are going to start this conference, and I invite Dr. Rohit Swami, who is a senior consultant medical oncologist at Narayana Multi-Specialty Hospital, Jaipur, and is my dear colleague also. He will be speaking on immune checkpoint inhibitors in first-line gastroesophageal cancer, which is also a new development in oncology. So, Rohit, over to you, please.
Yeah, thank you, Dr. Tarachand, for such a nice introduction. So, good evening, everyone. And I'll be having discussion on the role of immune checkpoint inhibitor in the first line in gastroesophageal cancer. So, my slides are not moving here. So, as we all know that at present, the standard of care for metastatic gastric carcinoma as well as gastroesophageal carcinoma is chemotherapy in the first line. And with the first line chemotherapy, we are having median overall survival of less than 1 year. So there has been unmet need since last 2 to 3 decades to have some novel therapies to increase this median overall survival in this metastatic setting. And luckily, since last 4-5 years, we are having such studies where immunotherapy is being incorporated in the first line with chemotherapy or dual immunotherapy, which is nivolumab, ipilimumab in this setting. And all of these studies which are incorporating immunotherapy with chemotherapy in the first line setting are using CPS score as the better marker for enrichment for efficacy of checkpoint inhibitors as compared to tumor cell PDN1 expression, as has been shown in several studies that CPS score is better marker of efficacy of checkpoint inhibitor in this setting. So there has been recently several studies like Keynote 590, which has shown survival benefit in the metastatic squamous cell carcinoma of esophagus, but with CPS score more than 10. So CheckMate 649 is the largest study among all of these studies, which has incorporated immunotherapy in the first line setting along with the chemotherapy. It is a global phase 3 study, and around 2041 patients has been enrolled in this study. And this study is this only study which has demonstrated overall survival benefit with incorporation of nivolumab with chemotherapy even in the patients where the CPS was less than 1. So I'll present this study. Next slide, please. So enrollment in Checkmate 649 study began in 2016, and this was a global randomized open label phase 3 study, and the key eligibility criteria were previously untreated, unresectable or metastatic adenocarcinomas of stomach or GEJ or esophagus, which has to be HER2 negative. There shouldn't be any HER2 positive status, and ECOG should be better 0 to 1. And these patients were further stratified as per their CPS score, which was either more than 1 or less than 1, as per the region they belong, Asia versus United States, Canada, or rest of the world, as per their ECOG PS, and as per the chemotherapy backbone they received, which was either Capox or Folfox. So the patient were randomized in 1:1 fashion in the 3 arms, nivolumab and ipilimumab arm, nivolumab with chemotherapy arm, and chemotherapy alone arm. In 2018, recruitment in ipilimumab and nivolumab arm was stopped because of the recommendation by data monitoring committee of this trial, which showed that ipilimumab and nivolumab is not giving better response rates. So around 789 patients were randomized in nivolumab plus chemotherapy arm, and around 792 were enrolled in chemotherapy only arm. And out of these 1581 enrolled patients, around 60% of the patient had PDL1 of CPS score more than 5. So this trial had dual primary endpoint, overall survival and PFS as measured by BICR was the primary endpoints. In the patients who had the PDL1 with CPS score more than 5. Secondary endpoints were to look for the OS benefit in all the randomized patient, as well as in the patient with CPS score more than 1 and CPS score more than 10, and overall response rate as measured by BICR. Other exploratory endpoints were safety and quality of life assessment. And sorry, at 12 months, which was the data cutoff at May 27, 2020, the median follow-up of this trial was around 12 months. Next, please. So if we look for the baseline characteristic of the patients, so baseline characteristics were similar in both the arms of the this study. Median age was around 60, and most of the patients were non-Asian, around 76%. Majority of patients were metastatic gastric carcinoma. Gastric carcinoma accounted around 70% in both the arms, and metastatic disease was in 96% of patients in both the arms, and with 40% had the liver metastasis. And signet ring cell carcinoma pathology, which has a poor prognosis with the chemotherapy, were equally distributed in both the arms, around 18% in both the arms. And microsatellite stable disease was around 90% in both the arms. And in both the arms, almost all the patients received the designated treatment as per the randomization. Next, please. So, coming to the overall survival and PFS outcomes in the whole population, intent to treat population in the all randomized patients. So there was significant overall survival benefit at the 12 month, which was the data cutoff of this study in 2020. Overall survival was 55% in nivolumab plus chemotherapy arm as compared to 48% in chemotherapy only arm. And median overall survival was around 13.8 months in nivolumab plus chemotherapy as compared to 11.6 months in chemotherapy arm. Even at the 2-year, which is the present scenario, after the minimal follow-up of 2 years, overall survival is around 28% in nivo plus chemotherapy arm as compared to 18% in chemotherapy only arm. Similarly, it also showed significant PFS benefit at 12 months. The PFS rates were 33% with nivolumab plus chemotherapy as compared to 23% with chemotherapy alone, and median PFS was around 7.7 months in nivo plus chemo as compared to chemotherapy alone. So this study showed superior overall survival benefit and meaningful PFS improvement in all the randomized patients, whatever their CPS score was. And in the CPS score more than 5, the overall survival benefit and PFS benefit definitely showed enrichment and overall survival, median overall survival in the group which was having CPS more than 5 was 14.4 months as compared to 11 months. And PFS was around 7.71 as compared to 6 months in chemotherapy only. Next, please. And on subgroup analysis is what seen that in all the subgroups, there is significant overall survival benefit with nivolumab chemotherapy arm as compared to chemotherapy only. The survival benefit was maintained with the region they belong, whether Asia or other words or US. And whatever the primary tumor location is there, whether it is gastric cancer or gastroesophageal junction or esophageal carcinoma, chemotherapy regimen used, whether FOLFOX or GILOX, there was a significant survival benefit. And the interesting thing is that PD-L1 expression, even it was less than 1%, there was significant survival benefit, though there was definitely overall survival benefit enrichment with the CPS score of more than 1%. And similarly, with MSI status, MSI stable disease also had significant survival benefit, but MSI-H, MSI-high had good enrichment of survival benefit, like median survival benefit, median survival was not raised in this group as compared to 12.3 months in chemotherapy only group. Next, please. And coming to the response rate of Nivo plus chemo as compared to chemotherapy alone, so overall response rate was around 58% as compared to 46%. And majority of responses were partial response. Complete responses were 10 in Nivo plus chemo arm as compared to 6 in chemo arm. And median time to response was similar in both the arms. It was 1.5 months in both the arms. And if we see for duration of response, so median duration of response in Nivo plus chemotherapy arm was 8.5 months as compared to 6.9 months in chemotherapy. So overall response rate was higher with nivolumab and chemotherapy, and there was more durable response in nivolumab and chemotherapy arm as compared to chemotherapy alone. Next, please. On the subgroup analysis, as per the CPS score, we can see that there is a clear-cut overall survival benefit even in the population which has a CPS score less than 1%. Similarly, with the PFS also, there was a significant PFS benefit even in the population with CPS less than 1. And similarly, response rate was also better in nivolumab and chemotherapy as per the CPS score. But definitely, when the CPS score reaches up to 5 or more than 5, then there is a significant enrichment of overall survival as well as PFS survival, as well as PFS, as well as objective response rate. Next, please. And coming to the treatment-related adverse events, so grade 3 to 4 adverse events were seen in 5% or less than 5% of patients which are on nivolumab and chemotherapy arm. And the most common side effects were gastrointestinal, followed by hepatic, followed by dermal side effects. And these were easily tackled in this study with the protocol, which was a standard of protocol as per the treatment of immunological drugs mediated side effects. Next, please. And time to symptom deterioration in all the randomized patients, we can clearly see that in nivolumab plus chemotherapy arm, the median time to deterioration of symptom was not raised as compared to chemotherapy arm, which was 24 months. So there was 23% reduction in risk of symptom worsening with nivolumab plus chemotherapy as compared to chemotherapy. Next, please. So coming to conclusion of this study, nivolumab plus chemotherapy demonstrated superior overall survival, meaningful PFS benefit, and all the previously untreated metastatic adenocarcinoma of gastric or gastroesophageal origin, despite of different CPS scores. And this combination had an acceptable safety profile. There was no safety signals, warning signals which were identified. And these treatment-related adverse events were with potential immunologic etiology were resolved in most of the patients with use of established management algorithms. Grade 3-4 events were less than 5% in nivolumab plus chemotherapy arm, and the quality of life was maintained with nivolumab and chemotherapy arm with decreased risk of symptom deterioration as compared to chemotherapy arm. And no additional bothersome side effects were seen with the addition of nivolumab to chemotherapy. So these data definitely support that nivolumab plus chemotherapy is now as a new first-line standard treatment for patients with metastatic non-HER2 positive adenocarcinoma of gastric or esophageal origin. Thanks.
Thanks, Rohit, for your wonderful presentation and nicely summarizing the role of immune checkpoint inhibitors in first line, which is the taste of India now at present. So now I invite Dr. Vishwajit Dovashi. He is a professor and head Department of Medical Oncology, JIPMER Pondicherry, and he is having special interest in GI cancer. So he will be presenting on the adjuvant treatment in stage 3 colon cancer, short versus long course. And I invite Dr. Vishwajit, please. Over to you, sir.
Yeah. Good evening. Thank you, Dr. Tarachan, for giving this opportunity. I think it's a very unique meeting which you conduct every year. And so I'll quickly share my screen. So is my screen visible?
Yes, sir.
Thank you. So the topic given to me today is one very interesting topic, which is adjuvant treatment in stage 3 colon cancer, which has changed over the last 3-4 years, where we could cut down the number of cycles of chemotherapy. In fact, in very few malignancies, we have looked at shortening the duration of chemotherapy, one in breast cancer with trastuzumab. And this was an interesting data where we could reduce the number of cycles of chemotherapy in a advanced colon cancer. So colorectal cancer in India, we know it's the 5th most common cancer, and we can see that in most of the registries, it seems to be, the incidence seems to be rising. And if you look at the history of the adjuvant therapy in colon cancer, in 1990, the first time they showed that 5-FU and levamisole was superior to surgery alone. And subsequently, they showed that the 5-FU leucovorin was superior to surgery. And subsequently, they did a randomized data between leucovorin versus levamisole. And they showed that leucovorin is much superior when compared to levamisole. And also then there was the data, the first time when the duration they looked at 6 months and 12 months treatment cycles, and they found that it was equal. And that's how 6 months therapy became the standard of care. And subsequently we looked at infusion regimes, and later on capecitabine and oxaliplatin was shown that it was similar to using a infusional regime. And then in the recent time, in the last 4 years, they've shown that even the 3 months therapy could be as effective as giving 6 months of therapy. So if you go by the timelines again, you can see that a lot of data in 90s used 12 months of therapy. Then in the mid 90s, we came down to 6 months of therapy. And now with the 2017, with the IDEA study, we can see that the 3 months were equivalent to 6 months, and especially in a stage 3 cancer. We also should understand that it's very important that we start the adjuvant chemotherapy on time, with this beautiful paper which says that if you actually start more than 8 weeks, then the benefit comes down. So apart from the duration of how much months we need to give the chemotherapy, we also need to understand that we need to provide the adjuvant chemotherapy as early as possible, and preferably before 8 weeks. Now, if you see colorectal malignancies, we can see that 50% of them will be cured with surgery alone, and 30% of them will recur in spite you give whatever therapy. So ultimately, the chemotherapy is beneficial in 20% of the patients. That's quite a huge number, but that also comes along with toxicity. So we must understand that we need to weigh a balance between the efficacy as well as the toxicity when we are prescribing an adjuvant therapy for these patients. So now so in 4 years back when the paper came out, whether we should do 3 months or whether we should do 6 months, it was very confusing, because it's not a properly, it's not a randomized prospective randomized clinical trial, because if you have to do a study like this, you will require in thousands of numbers of patients. So they looked at a different way of analyzing this problem, and that's how they came out with this pooled analysis with the IDEA collaboration, where actually 6 different studies were pooled. So there were 6 different studies, like the TOSCA study, the SCOT study, the IDEA France study, the C80702 study, the HORT study, and the ACHIEVE study. So these were across different parts of the world. Most of them were in Europe, US, Asia. So they covered almost all the parts of the world. And from this, the patients were pooled. Patient data was pooled to look at the efficacy of 3 months versus 6 months. Now, when they actually started designing the study and looking at the sample size, so they assumed that a 3-year DFS of 72% would be ideal. And that data basically came from the Mosaic study and the N0147, where the data was that 3-year DFS was around 72% in a stage 3 colon cancer. They said that at least 10,500 patients would be required. And if the accrual duration would be around 4.5 years with an additional 1.5 years of follow-up, they expected a 3,390 DFS events with a 90% power for analysis. And since it was a non-inferiority design, they defined that the upper bound of the two-sided 95% confidence interval should not exceed 1.12. So it should be less than 1.12. And in terms of 3-year DFS also, they defined the non-inferiority margin as minus 2.7%. So we just need to keep this figure in mind, that the non-inferiority margin was kept at 1.12. So this was the group of patients which were involved in the 6 studies, which you can see that low risk group where majority of the patients were low risk in most of the studies, and CAPOX as well as FOLFOX was used. And again, the CAPOX and FOLFOX has been used differently in different countries. So you could see that in some studies like the SCOT study, where the CAPOX was used in 66%, whereas in France they majorly used FOLFOX. So US and Canada again use a lot of FOLFOX because they don't like capecitabine. They also looked at the follow-up, and I think most of them had a reasonable duration of follow-up. And when they looked at the 3-year DFS, it was almost similar. The details I will show you in the next slide. And if you look at the neuropathy, which is the most problematic issue after 3 cycles of CAPOX, it was definitely double when compared to 3 months versus 6 months, both in the FOLFOX arm as well as in the CAPOX arm. Now, the type of patients included, we can see that around 20% of the patients were T4, and the rest of the patients were T3. And N2 disease was seen again in 28 to 30% of the, almost around 30% of the patients. Now, what happened to the curve? When they looked at the 3-year DFS, the 3-month DFS was 74.6%, and the 6-month DFS was 75.5%, which was almost similar. And the hazards ratio was 1.07. But if you look at the upper border of the confidence interval, it was 1.15, which I told you in the previous slide that it should not have crossed beyond 1.12. So at the median follow-up of 41.8 months, the non-inferiority between 3 months and 6 months was actually not confirmed for the entire treatment intention to treat population, since the hazard ratio for the upper limit confidence interval had crossed 1.12. When they did a subset analysis, they found that patients with CAPOX, definitely the hazard ratio did not cross, and it was non-inferior for 3 months versus 6 months. And if you see the low risk group, the higher end of the confidence interval touched 1.12. Ideally, as per the statistics, it should have been less than 1.12. So these are the 2 situations which was found positive in the study, where they said that 3 months versus 6 months, CAPOX is good, FOLFOX is not very good, and that low risk patients you could actually bring down the duration of therapy from 6 months to 3 months. So this was again confirmed on the forest plot. And so if you see this diagram here in the forest plot, you can see that T1 to T3 and N1, which is the low risk. You could see that this blue line is the line of highest interval of the confidence interval, and this graph should not cross this this line, which is 1.12. So for the low risk, it just touches, whereas for T4 N2, it definitely crosses, and in fact, it actually crosses even the hazard ratio of 1. So probably in T4 N2, we need to be very careful if you are going to bring down the duration of therapy. Now, if you see FOLFOX and CAPOX, again, you can see very clearly that the CAPOX was non-inferior because it did not touch the non-inferiority margin. Whereas you could again see that FOLFOX was definitely inferior because it crossed the hazard ratio of more than 1. So definitely CAPOX is non-inferior when compared to 3 months versus 6 months, but FOLFOX was inferior. So with coming to the safety, again, we can clearly see that between 3 months and 6 months, obviously the side effects will double, and especially with neurotoxicity and diarrhea, we need to always keep in mind and balance between the efficacy versus the toxicity. So the conclusion from the IDEA study was that the non-inferiority for 3 to 6 months was not established in the entire population, but you could consider probably for low risk patients, which was T1, T3, N1 disease for 3 months, as discussed previously. And we must also understand that the shorter duration would have more compliance and less grade 2 neuropathy. So recently, the IDEA collaboration published their overall survival data, which was in 2020. And for the overall survival, they said that the non-inferiority margin was to be kept at 1.11, and non-inferiority was declared if the one-sided false discovery rate adjusted p-value was less than 0.025. So just keep in mind that the non-inferiority margin was 1.11 and the p-value should have been less than 0.025. So the updated DFS results, not the OS, this is the DFS results. Again, you can see the confidence interval is still 1.15. Remember that it was 1.12, which was the cutoff. So they were still not able to demonstrate the non-inferiority between 3 months versus 6 months. But when it came to the overall survival, also, though the confidence interval touched 1.11, which was kept as the cutoff, the p-value was 0.05. It should have been less than 0.025. So for the OS also, they were not again able to demonstrate the non-inferiority. So the conclusion was the non-inferiority of 3 months versus 6 months for patients with stage 3 was not confirmed in overall survival. But remember that the absolute difference is only 0.4%. It's very, very small. And we should keep this in mind when we are having it, when we discuss with our patient. So here in stage 3 cancer, when we are deciding between 3 months and 6 months, it becomes imperative that the patient decision also needs to be taken into account. So final conclusion that 3 months is still non-inferior, but substantial reduction in toxicities were seen. So there was an interesting paper in Annals of Oncology where they looked at this 3 to 6 months. And in fact, a group of physicians had, in one of the meetings, had worked together and looked at a meeting where they actually asked questions to the not only to the treating physicians, but also to the patient advocates to see what would be their response if they were asked to take 3 years of 3 years versus 6 months, CAPOX versus FOLFOX. So again, as the data shows, we know that for 3 months, if you are using CAPOX, definitely non-inferior. We have shown that data. If you're using FOLFOX, definitely inferior. That also we have shown the data. So FOLFOX definitely no, especially for T4N2 disease. And what is not proven is we don't know the FOLFOX for low risk, and we do not know the CAPOX for the high risk. So they came out with this interesting concept in that meeting where they said that we could divide the groups into two. We could call them as fighters. If you are ready to accept if they want even 1 to 2% reduction in efficacy, they were prepared to accept that. Whereas fatalists said that unless there is a 2% reduction in efficacy, we do not want the particular treatment. So the fighters are willing for even for whatever may be the benefit we would want to take, and the fatalists are one who will only accept more than 2%. So they divided into two groups, the fighters versus fatalists among the physicians as well as the patient advocates. And you can see that so there was no confusion for the fatalists because they were there, all of them voted for Capox into 3 months, whatever may be the situation. But the fighters who were ready even for less than 1% of the benefit, you could see that for high risk and T4 N2 disease, and between FOLFOX and Capox, where they said that we would want Capox, and for high risk T4 patients, again the data for T4 where we need to give 6 months of Capox, there were more fighters. So again, what this again tells us is that it's not an easy decision, especially for high risk patients, T4 N2 disease, where you need to discuss along with your patients and decide whether you can reduce. But definitely, I think for low risk T3 N1, I think we can definitely give 3 months of Capox. What are the unresolved questions? Can we take T4 N2 disease similar? Because we know that T4 is more powerful negative prognostic factor than N2 disease. So something which we need to think about when we are reducing treatment for T4 disease patients. And is the tumor sidedness important? In fact, the SCOT trial looked at this, and there was some data. It was only in the SCOT trial which they looked, and there was some data to say that tumor sidedness would also affect deciding on the adjuvant therapy. Again, this is unclear. Are there any tumor-specific biomarkers such as MSI, molecular subtypes, BRAF, KRAS mutations, immune cell infiltrates, and other markers which can help us decide a treatment between 3 months versus 6 months? And I think one of the papers which came out recently was on the circulating tumor cells, which we have seen whether in future the circulating tumor cells, that was mainly for the high risk stage 2 disease, but maybe something like that can be worked on stage 3 cancers. And these are the mutations, these are the biomarkers which are being studied. And that's fourth question is, what is the optimal duration of therapy for elderly patients? We know that if in elderly patients, we could still cut down the therapy even probably for high risk patients, because the side effects of the therapy is there. Is there any data to show this? Again, we are not sure between 3 months and 6 months. Is 6 months therapy really necessary for both oxaliplatin and 5-FU? So we could develop a different regime where you give 3 months of Capox and give 3 months of capecitabine and just omit the oxaliplatin for 3 months. Again, we do not have such a data to prove. So the take-home message, definitely short and long-term, short-term, definitely for low-risk disease, T3 and N1 disease. High risk, we need to discuss with the patient. Definitely FOLFOX, no. If you're going with 3 months, then it has to be Capox. But again, if it's a young patient, we could again do a 6 months probably, because we are not yet proven a non-inferiority for 6 months for a high-risk patient. So thank you. I'll just stop here.
Thank you, sir, for your nice presentation, and sir, both very crisp and clear message then how on which setting we can use the short regimen, and it is yes really helpful in low risk cases where we can if the patient is elderly, and low risk case we can go with the 3 monthly regimen with the Capox. Thank you, sir. Now
Sir,
for the
excuse me,
next
sir, there is one few questions Q&A section. 1 or 2 questions are there. Q&A, question and answer section, sir.
No, in there, I think it was for the Rohit first question, and second is
that is
compliment for the sir.
So
That is only, yeah. Okay, so now for the next talk, total neoadjuvant therapy versus conventional approach in stage 3 rectal cancer. For this, I invite Dr. Siddharth Turkar. He is the director of Radiant Super Specialty Hospital, Super Specialty and Cancer Hospital in Raipur. Yeah, Dr. Siddharth, Please.
So my presentation is visible to everyone.
Yes.
Okay. So I will be talking about the total neoadjuvant versus conventional approach in stage 3 rectal cancer. So these are the sequence of how I am going to discuss this thing. First, I will discuss a brief overview of diagnostic evaluation and staging. Then the treatment strategies that are there for stage 3 rectal cancer. What are the key clinical trials results with TNT versus conventional treatment, and the meta-analysis of different trials. And then I will be briefly presenting the evidence of dostarlimab. So starting with the diagnostic evaluation, I will keep it very brief. So first, as you can see, this is from ESMO guidelines. After a digital rectal examination and endoscopy, we generally decide the location of the tumor, whether it is low rectal, middle rectal, or high rectal cancer. So this is how the diagnostic workup goes. The location is decided by a digital rectal examination and rigid sigmoidoscopy, then a morphological verification by biopsy. Clinical staging is done by MRI, and sphincter infiltration end stage, M stage is decided by mostly MRI, and then CT abdomen and CT thorax. So all the patients need MDT discussion. Now coming to the staging, as I am talking about stage 3 rectal cancer. So all the cancer which are N1 disease means they have metastasis in 1 to 3 regional lymph nodes, or they have tumor deposit, that is satellites in the subserosa or non-peritonealized pericolic or perirectal soft tissue without even regional lymph nodes metastasis comes in N staging. So all these patients who have N1 or beyond disease are considered in stage 3 rectal cancer. So this is the pictorial depiction of stage 3 rectal cancer. Now, what are the treatment strategies for stage 3 rectal cancer? The first one, surgery followed by chemotherapy and post-operative chemoradiation. It is mostly obsolete because in most of the cases, we go ahead with neoadjuvant RT at least. The second approach is to go ahead with long course chemoradiotherapy followed by surgery, followed by adjuvant chemotherapy, or short course RT followed by immediate surgery, followed by adjuvant chemotherapy. Then there are some total neoadjuvant approaches like short course RT followed by chemotherapy, followed by delayed surgery, followed by adjuvant chemotherapy, or induction chemotherapy followed by CTRT, followed by surgery, or neoadjuvant chemoradiotherapy followed by consolidation chemotherapy, followed by surgery. Now, we can see in the NCCN guidelines, they have updated that both the strategies of total neoadjuvant treatment versus the conventional treatment, that is chemoradiotherapy or short course RT followed by surgery, both are acceptable, but the preferred one is total neoadjuvant treatment, where we give either induction chemotherapy followed by chemoradiotherapy, or we give chemoradiotherapy followed by consolidation chemotherapy followed by surgery. I will briefly tell you what is the benefit of adding RT. So you can see that most of the studies have demonstrated that local failure decreases by about 50% with use of adjuvant radiation therapy, with a greater effect when concurrent 5FU is used with RT. So there are multiple meta-analysis where they have seen that the 5-year mortality local recurrence was also decreased with preoperative radiotherapy versus just surgery. And the yearly risk of local recurrence was decreased with both preoperative and postoperative RT, but the death rate was particularly decreased with preoperative RT. So these studies have led us to the notion that neoadjuvant chemoradiotherapy at least should be given before surgery, especially in stage 3 rectal cancer. Now coming to what agent we use for concurrent chemotherapy. So we either use capecitabine or 5-fluorouracil. So in this non-inferiority trial, it has been shown that both capecitabine was found to be non-inferior to 5FU, in fact numerically better in terms of the overall survival and disease-free survival. So it became the standard of care. Again, capecitabine and oxaliplatin was also used, but in this trial, they have seen that capecitabine is non-inferior to 5FU and oxaliplatin have not impacted anything in NSA BP R04 trial. So this led us to go ahead with our standard treatment, that is neoadjuvant chemoradiotherapy with capecitabine radiotherapy or 5FU RT. Then coming to what are the key studies for total neoadjuvant treatment. So first we will be talking about the Rapido trial. In this short course radiotherapy followed by chemotherapy before surgery they have done, and they have compared it with long course chemoradiotherapy followed by surgery followed by adjuvant chemotherapy. So as you can see that there was not much difference in overall survival and loco-regional failure. So it was not significant over there. But you can see in the graph that the disease-related treatment failure and distant metastasis-free survival was better with experimental group. There were more disease-related treatment failure and distant metastasis failure in the standard of care group. So that was the advantage seen with in the Rapido trial. Then there is a Stellar trial. It also has almost the same kind of design with short-term radiotherapy followed by consolidation chemotherapy followed by long course radiotherapy. Here also what they seen that there was some overall survival benefit also with total neoadjuvant treatment approach. There was some disease-free survival benefit also. But they see there was not much difference in metastasis-free survival between the two subgroups, and there was not much difference in loco-regional failure. The p-value was non-significant. Then there was one more study where they have tried to intensify the chemotherapy. So they have used FOLFIRINOX in the induction chemotherapy, and then they have given chemoradiotherapy, and they have seen that those patients who have received intensive treatment, neoadjuvant chemotherapy has better disease-free survival, and overall survival was also improved in this study. The metastasis-free survival was also statistically better in those who have received neoadjuvant induction chemotherapy in an intensified manner. Then there was an approach that was being tried, that watch and wait approach. In these, you can see the clinical, complete clinical responders were compared with a cohort of patients treated similarly who underwent surgery for complete resection. And after a median follow-up of 33 months, they found that around 34% of the patients who choose watchful waiting had local recurrence, and 36 patients had a salvage resection. Although the 3-year overall survival and 3-year colostomy-free survival was numerically better, but that was because the most of the patients who underwent watchful waiting was early stage disease and had a better prognosis and lesser high risk factors. Then there is an OPRA study. In this, they have compared the two neoadjuvant total TNT approaches, starting with induction chemotherapy followed by RT, or RT followed by neoadjuvant, RT followed by consolidation chemotherapy. And here they have seen that there was not much difference in disease-free survival and disease metastasis-free survival, but there was a better pathological CR rate in those who have received RT followed by consolidation chemotherapy. Now, because of these mixed results, this meta-analysis was also done to see whether there was how significant was the benefit. So what they have seen in the overall group who have received total neoadjuvant therapy versus standard chemotherapy, but obvious that they have better PathCR rate. You can see in most of the trials that the PathCR rate is favoring the total neoadjuvant treatment group. In the subgroup analysis, those who have received the induction versus those who have received consolidation, in both the groups, it was better than standard treatment in terms of PathCR rates. Although chemoradiotherapy followed by consolidation chemotherapy was somewhat numerically better. Then they have also divided in this meta-analysis into TNT-like versus TNT. So TNT-like means those who have total neoadjuvant treatment less than 12 weeks versus total neoadjuvant treatment more than 12 weeks. So those who have total neoadjuvant treatment more than 12 weeks have better numerically versus standard treatment. Although TNT-like strategies where it was less than 12 weeks of total neoadjuvant treatment, it was still better than the standard treatment. So you can see in the forest plot. And in the subgroup analysis of long course radiotherapy versus short course radiotherapy, here you can see that again, the short course radiotherapy trials have shown better PATCR rates as compared to long course radiotherapy. The overall, it is better than standard treatment in both the groups. The reason might be that in short course radiotherapy, they have received consolidation chemotherapy after RT, prolonging the duration between radiotherapy and surgery. Now, coming to the disease-free survival, in this meta-analysis, they showed that there is improvement in disease-free survival and disease metastatic-free survival. You can see that those who have TNT treatment, it is favoring that they have better disease-free survival. Although the overall survival was numerically better in the TNT group, but there was not it was not statistically significant in this meta-analysis. Also, local recurrence-free survival was almost same, and it was also not statistically different between the TNT versus standard treatment group. The distant metastasis-free survival was better in the TNT treatment group, and it was statistically significant. R0 resection rate was equal between the two groups, and because obviously those kind of patients were only chosen. Now, coming to the safety between the two approach, the grade 3 and 4 toxicity seen in various TNT group was 9% to 41% than in the standard treatment group. In most of the clinical trial, there was some increase in toxicity with TNT group, but it was not affecting the survival in most of the case studies. And gastrointestinal side effects, the side effects include gastrointestinal, diarrhea, nausea, and hematology, and fatigue were the adverse events seen. Overall, the surgical method used and the main post-operative complication of TNT regimens were almost comparable with standard chemoradiotherapy group. So before coming to the complication conclusion, I just want to highlight that there is a recent evidence for a new checkpoint inhibitor, dostarlimab, for locally advanced dMMR rectal cancer. So standard treatment for locally advanced rectal cancer typically involves chemotherapy, radiation, or surgery, but up to 25% of the patient achieve PATCR with standard approach. Around 5 to 10% of rectal cancers are dMMR positive and are poorly responsive to chemotherapy. That's why they have tried to give these patients initially induction dostarlimab for 9 cycles, and if there is any residual disease, they have undergone chemo-RT followed by surgery, and those who have complete response, they were kept for watchful waiting. In this study, all the 14 early patients were found to have complete clinical response. The toxicity was also not significant. It was less than 5% in most of the cases. So it is it might be a promising option in the future. But right now, we don't have enough evidence to still include that in the current guidelines. So coming to the conclusion, the TNT may help improve the PATCR rate, increase DFS and OS, and reduce the risk of distant metastasis compared with standard neoadjuvant chemoradiotherapy among patients with locally advanced rectal cancer. Although it has not proven to be statistically significant in most of the trial in terms of overall survival. And in TNT approaches, the sequence of chemoradiotherapy followed by chemotherapy and then surgery had a better result, significantly higher PATCR than the standard regimen of induction chemotherapy followed by chemoradiotherapy. And in those patients where a good response is needed, we can intensify the treatment with use of regimens like FOLFIRINOX to better get the results of spincher preservation. Thank you.
Thank you, Siddharth, for elaborated presentation and touching every point of this topic, and which is a flavor of today only. And we can see that now in the many malignancies, the concept is the total systemic therapy before the surgery, and then go for the definite treatment, so that we can get the best results now. So now the next is the panel discussion on the metastatic colorectal cancer. For this panel, I invite.
Can we wait for 5 minutes? Triple sir will be joined.
So till then, we can have a question answer session. If
Yeah,
anybody
yeah.
want to ask any questions, they are most welcome.
So Siddharth, what do you recommend nowadays? We should go for the total neoadjuvant therapy, or which segment should we use, or otherwise we go for the traditional today?
So I would prefer total neoadjuvant treatment. There is no harm in going ahead with that. We have few advantages of getting a better PathCR rate and better sphincter preservation in this patient, and we almost have an answer that we can avoid surgery if those patients who have a very good response, if they wish to. Although I am not in favor of not going ahead with the surgery in cases of rectal cancer. As you can see, around 34% of the patients do relapse, and they can have a more morbid surgery later on. So
And do you categorize patients in a high risk or low risk person for the total neoadjuvant, or every patient you want?
So right now, in all the stage 3 rectal cancer, we may categorize, but it is better to go ahead with total neoadjuvant treatment in these patients, even whatever the case, because in high risk, it is going to definitely be better because they have higher risk of metastasis also, and it has been shown that the distant metastasis-free survival is better in this group. And so better to give that. And those early cases, we can have an option of avoiding the surgery also. So better to go ahead with the newer treatment regimens. Also, the chances of completing the treatment with total neoadjuvant treatment is more than in those cases where we go ahead with surgery followed by chemotherapy. Because in many cases, when surgery is being done after that, because of surgical complication, adjuvant chemotherapy is very much delayed. So the duration of treatment is prolonged, and sometimes we don't get the result that is being seen in the trials. So it is better to consider completing the total neoadjuvant treatment first and then going ahead with surgery.
So you are always a GI champion, right? As always from the degree time, right?
Yeah, thank you.
So it is now time to convince all the radiation and surgical colleagues also that it's a good time. I think we should shift for the total neoadjuvant therapy first. Any question from the other audience? Gitka, how much time is taking now in joining?
Sir, उन्होंने 2 minutes बोला है, वो login नहीं कर रहे हैं.
Okay.
Issues आ रहे हैं login के लिए.
So actually, we usually some of our colleagues know already that we usually organize this type of conference nearby every year to make our clinic practice actually easy going. Then last year, yes, we make it as an experiment or for a summarize also, and Siddharth was also the part of that webinar at that time also, and the Rohit also, that we usually summarize all the tumors so that we can aware of the what is the going on and what should be the latest protocol for the treatment purpose and for the diagnostic and staging purpose. So last year we also did in all the tumors. Now we have moved forward from that end, and from this year we usually summarizing the this year's treatment only, so that we can update our previous practice.
In your center, you are going ahead with short course RT or long course RT?
I advise one patient, but you know the circumstances what happened, that I planned one patient and sent for that. Meanwhile, he was convinced from the different centers, many of the centers. Then why are you giving us so much treatment? Then the people are treating with the like then short with the traditional view that chemo radiation, and it may be a toxic also. We have to take the more
So
chemotherapy.
if you give TNT treatment, because that was the question somebody should have asked. I was searching for it. Then after completion of radiation, how much duration you give for chemotherapy? So
Usually we were giving in traditional view on the already the 6 weeks is the CTRT, and then the remaining 4.5 months was the chemotherapy.
it was 6 weeks, 6 to 8 weeks for the surgery, right? For chemotherapy, if we are giving consolidation, it is in various trials, it is around from 7 days to 18 days that is being seen in the various trials. Between the radiation and chemotherapy. So we don't wait for 6 weeks for starting.
No. Sorry, I missed your question. I was just talking about the traditional. Yes, for the post radiation, usually we take the 1 week gap to recover the pelvic marrow only.
Yeah.
Then we start the chemotherapy, and if the counts become normal, and then we start. How is Lalit? What is your view on this? Welcome, Lalit, here. Lalit Sharma is a senior consultant medical oncologist in Manipal
I
Hospital.
don't have pretext to it. Yeah, Tara, I just joined in, so I don't have a pretext to it. What actually
Yeah, we were Lalit, we were talking about that the recent talk which were delivered by Dr. Siddharth Turkar, consultant medical oncology from Narayana, Raipur. That the total neoadjuvant therapy versus a traditional treatment in rectal cancer. So his view is that we should finish in before the surgery, so that sometimes patients after surgery has the complication and the surgery gets delayed, the chemotherapy gets delayed, and the results are compromised. And actually the data is also in supporting that, at least in T3, T4 category, that we should start with a node positive disease, we should start with the TNT regimen. So what is your opinion on this?
I would agree to the notion that the tolerability definitely goes down post-operative because of the various reasons. One is the patient is recovering to the nutrition being not that well. So if now that we have accumulating data also to it, so definitely finishing the chemotherapeutic part before the surgery would be kind of very well considered, could be very well considered.
So you have started using at Manipal that total neoadjuvant therapy or not?
Well, not in all cases.
Do you start with chemotherapy or you start with the radiotherapy first? Chemoradiotherapy followed by chemotherapy, or chemotherapy followed by chemoradiotherapy? Now, both the approaches are there: consolidation chemotherapy versus induction chemotherapy. So consolidation is found to be better in terms of FCR. Although OS and rest of the all things are same with both the approaches.
So we are kind of doing it on case-to-case basis. No kind of.
I think Krupa Shankar sir has joined. Good evening, Dr. Krupa Shankar.
Good evening, Dr. Krupa Shankar.
Hello.
Hi. Now this is your dice, and we are for the panel discussion on metastatic colorectal cancer. Dr. Krupa Shankar is a senior consultant medical oncologist at NSR Cancer Center, Coimbatore. And for this session, the panelists are Dr. Devesh Goyal. He is a senior consultant medical oncologist, Fortis Hospital, Jaipur. Dr. Lalit Sharma, consultant medical oncologist, Manipal Hospital, Jaipur. Dr. Aditi Mittal, she is also consultant medical oncologist, SMS Medical College, Jaipur. Dr. Rohit Rubelo, he is also the assistant professor medical oncology, Ananta Institute of Medical Sciences, Jaipur, and myself also. So, Dr. Krupa Shankar, dice yours.
So Dr. Aditi Mittal, she is not joined. She is busy in OPD.
All right, that's fine. All right, Dr. Aditi has not joined us, I guess,
Okay.
but I guess the rest of us are here, so I think we'll go ahead. I'll share my slides and we'll start right away.
So request all the panelists to switch on their video to have an interactive session.
hope my slides are visible and I'm audible.
Yes, sir.
So, thank you. Very good evening to everyone and a warm welcome to everyone as well. And at the outset, before I begin, I'm going to take this opportunity to congratulate the organizers and also thank them for the opportunity. So without wasting any further time, I'm going to get right away into the discussion. So this is the sort of scenario that we're going to go across today. What do we do in a newly diagnosed MCRC patient? What are the upfront considerations? What are the principles of management? The subtypes and influence on the first line management, maintenance, second line, and if time permits, third line and beyond. So let me begin with Dr. Lalit here. So Lalit, whenever you get to see a patient with metastatic CRC, what are the factors that you would take into account before you start the patient on treatment?
Well, sir, the factors which we would like to consider is one is the what is the performance score of the patient, what comorbidities the patient has, and whether the patient has received any prior treatment or not. Then from the disease side, one is what is the extent of the disease, and even on the, like we are talking about metastatic, so what all organs are involved and whether the patient is currently in an obstruction or not. And then the tumor biology also to start with, what is the RAS status of the patient, whether the patient is MSI high or not, and for the rarer mutations also. And gradually over the period of time, how the patient behaves on the treatment would also give us an idea of what the biology of the disease is.
I think the first and foremost thing is the intent of treatment here. Whether we're looking at a patient who's going to probably be fit enough for cytoreduction later on, is it liver limited metastatic disease or not? And then the tumor site, the location, the sidedness, and then the fitness of the patient, and again the tumor characteristics. All of this definitely should be taken into account. But I think the most important thing probably is your intent of treatment. Are we looking at somebody with liver limited metastatic disease or borderline resectable or unresectable disease? Because that really forms the cornerstone of treatment. So I'll just move on. I'll probably bring in Dr. Tarachand here. So in your practice, what do you do as far as biomarker testing is concerned? Do you only go with a PCR or do you do broad-based NGS panel right up front? And if so, why?
Yes, sir. Now the taste of oncology is the NGS if the patient is in metastatic setting, especially, and I go with that only so that I can find, it helps me in many ways that first I can find the usual markers which I know, which can be used in the clinical setting. Should we use first line immunotherapy or other or chemotherapy or whichever the targeted therapy whatever. And second thing, same time we can find sometimes unusual targets with therapeutic targets which can be used in this desperate settings also. So that's why I go with the NGS.
All right. So Dr. Divesh, your thoughts? What do you do in practice?
Agree with Dr. Tarachand, but a few companies and are doing the colon cancer or rectal cancer specific panels. So I am focused on MSI, MMR, as well as the PANRAS, BRAF, as well as PD-L1 and that is HER2. So I think I am focused on this because the treatment of the modality is available on these parameters. So I usually just colon specific panel, so helpful for deciding further treatment options.
All right. So you're saying you'd probably do only the PAN-RAS, RAF, and MSI alone. Is that right, Dr. Divesh?
With including HER2 also.
Including HER2 also. So why do you specifically want to know about HER2? Do you think it's going to impact on your first line management?
No. It's I am doing on first. I am doing first on first time because I will do all these tests on first one sitting, single sitting. So one by one options can be explored in sequential way.
Yeah, fair enough. I think, as far as from a therapeutic point of view is concerned, doing a PAN-RAS, a BRAF, and MSI is good enough. But again, if you want to look at the downstream signaling pathways like HER2, PI3K, then because if your downstream signaling pathways are still active, you cannot use your EGFR inhibitors right up front. So it's got a negative predictive value, which is why probably you're fair enough and justified in doing an NGS upfront because it helps you pick up those rarer mutations as well. And also does, then you can also decide on whether you want to do an EGFR or a VEGF blockade right up front. So I think for that matter, yeah, you could do an NGS right up front. So this is just a look at the prevalence of BRAF and RAS mutations according to the tumor site and the MSI incidence as well. And as you can clearly see here, there is a difference in the incidence of MSI. See, when you talk about MSI high tumors, especially in the metastatic setting, we know it's only around 5%. So that's a very small number. But even in that 5%, look at the incidence varying from whether it is in the ascending colon, the descending, meaning the right versus left as well. So I think that that's sort of important for us to understand that these mutations vary depending on the sightedness as well. So let's move on, and I'll probably bring in Dr. Rohit here. So this is something that's always been debated upon and probably will keep being debated upon for decades to come as well, right versus left. So in your practice, right versus left, what do you do in practice? What would be your choice of treatment in the first line setting for somebody with right-sided colorectal cancer? Bring in Dr. Rohit here.
Yeah. So as we all know, these cetuximab and panitumumab, they generally don't work on right-sided tumors, even if they are all wild type. So the guidelines, I think ESMO, NCC, and everything says that you even if they are wild type, you don't go in for cetuximab and panitumumab. So it's more, you'll be more in favor of something like bevacizumab in a right-sided tumor, whereas in the left-sided tumor, based on the RAS as well as HER2 status, you can put these patients on cetux or panitumumab.
So so left-sided, do you believe there's still a role for bevacizumab, or is it over? It's only you have to go only the EGFR pathway.
No, if the left-sided tumor is if there's any RAS mutation, or even if HER2 is present, I think then actually it does have in HER2 also it doesn't really work. Your EGFR inhibitors don't work if HER2 is amplified. So in those kind of situations, I think I'm more in favor of going for bevacizumab even in a left-sided. But if it's wild type, then
if it's a completely wild type, or do you have a choice of preference between EGFR inhibitors versus CMAB or PMAB, meaning cetuximab or panitumumab? Have you ever used panitumumab in your practice? And how do you choose between cetuximab and panitumumab?
Actually, there is no, the phase 3 data has now come out for panitumumab also. So there's no actually, both of them are kind of similar now. It's, I think, more of personal choice. Just the cetuximab has more mature data, and I've used both. And, my experience has been quite similar with both of them.
I think the key thing that you rightly pointed out is that we know that both of them are very similar. There's non-inferiority. There's a phase 3 trial which is looked at, comparing cetuximab with panitumumab, called the ASPECT study, which has actually shown non-inferiority of the PMAB versus CMAB. So you're justified in choosing panitumumab as well. Probably the incidence of infusion reactions is much lesser. You can use it once in 2 weeks as well. 6 mg per kg body weight dosing as well. So it's pretty comfortable. You can use it. Let's not forget about panitumumab because the focus is always on cetuximab. But panitumumab is definitely a very valid option here as well. I think, the one trial that's probably settled this debate on left versus right is the Paradigm study, which got presented at ESMO just about a few months back, which was, looking at left-sided completely wild-type tumors. And we know now that panitumumab, or for that matter, EGFR inhibitors are better if you have a completely wild-type tumor on the left side. So I think that debate right now at least is settled, at least in left-sided completely wild-type tumors, EGFR inhibitors are the way to go. And as far as the right-sided tumors are concerned, VEGF inhibition still has a role. So we'll get to that. And this is just to understand as to why, when we use a VEGF inhibitor right up front, and subsequently your EGFR inhibitors do not work as well, because they get desensitized to subsequent lines of therapy. And also rapid tumor responses and early tumor shrinkage is much better with your EGFR inhibitors as opposed to VEGF. So if your goal of treatment is cytoreduction, if you have somebody with a liver-limited metastatic disease where you're looking at conversion therapy, then you're looking at EGFR inhibitors because they have a better response rate. So I'll just quickly move through this. This is how, as far as sequencing is concerned. So I think this is another important question. So we all spoke about EGFR versus VEGF. So what about the backbone chemotherapy agent? Would it be a doublet or a triplet? I'll again get back to Dr. Lalit here. So Dr. Lalit, would you prefer using a doublet or a triplet in practice, depending on your goal of treatment?
Well, sir, usually we'll end up using doublets only, but in specific scenarios wherein the patient is in a really good functional status and we are trying to convert borderline resectable to resectable, maybe I would be tempted to use the triplet, but most of the times we'll end up using doublet.
Use a vending doublet. All right. So Dr. Rohit, any place where you would look at using a triplet, along in combination with a targeted agent? for
So
these drugs?
I think the data right now, I mean, in the sense, I think cetuximab and panitumumab, I think the data from the INCOR trial or something like that showed that there is inferiority of adding cetuximab, panitumumab when you're going in for a resection. So in these kind of situations, I think if a patient can tolerate, a triplet, I think a triplet is is better without targeted therapy.
All right. Okay. Dr. Tarachand, your views?
Usually, sir, I use a doublet therapy if it is a clear-cut metastatic setting for me. Then we cannot go for the surgery in future if after the discussion with the surgeon. But if it is nearby borderline or sometimes it is oligometastatic disease, then usually I go with the triplet FOLFIRINOX.
So I think to probably put it in a nutshell, if you have a left-sided tumor, then probably a backbone of a doublet chemotherapy is good enough. But in a right-sided tumor, especially, we know that they have a higher incidence of RAF mutations. They are biologically more aggressive. They have poorer outcomes. So, you're justified in actually using a triplet if you have a young, fit patient with a right-sided tumor, yes. And if the patient is fit enough to tolerate a triplet, and if your goal of treatment is actually looking at cytoreduction later on, then yeah, you justify using a triplet in those patients. So I mean, this is just look at the data that we have as far as using a triplet with bevacizumab. The TRIBE and the TRIBE2 studies have actually shown an improvement in overall survival with using a triplet upfront. So right-sided, yeah, definitely a triplet is probably good enough. But left-sided tumors, doublet alone is probably good enough if you have a completely wild-type tumor. So, like I said earlier, probably HER2 mutations, targeting them, we're not yet ready for using it right upfront. But post-progression on the first line of treatment or post 2 lines of therapy, there is phase 2 data based on the Heracles and the My Pathway and Mountaineer, and so many studies looking at even dual HER2 blockade in the second line and third line onwards. So I'll just move on quickly to the next thing, which is, we all know this. I mean, like we've already spoken about doing an MSI testing on IHC. So if you pick up an MSI high tumor, I'll bring in Dr. Divesh here. Dr. Divesh. So let's say you have a patient who's got let's say you have a patient who's got an MSI high tumor in the first line. So what would be your treatment option? What would be your choice of treatment?
So I think recent data is presenting pembrolizumab can be used wisely in the MSI high and upfront settings. I think various trials are showing the positive results with this using agent in upfront first line setting. But personally, I have no experience of this MSI high in any one cases in my 10 years practice. So I think I am not in situation to comment actual things. But various trials and various data are saying that pembrolizumab can be used in first line if there is MSI high. And second thing, if there is affordability is good, so that we can take a chance and can start upfront pembrolizumab for initially 4 months. Then we can see the response and evaluation. Then we can plan further.
All right. So, interestingly, something that I wanted to discuss with all of our panelists is, we were all very impressed with the PFS data. There was a doubling of the PFS, 16 versus 8 months. But now the OS data, at least the update of the interim analysis on the OS data is out. And here, as you can see here, the OS data is not that great. So I'll probably bring in Dr. Rohit here and get his thoughts. Rohit, so why do you think that is the case? Because, we've always known that with IOs, especially immune checkpoint inhibitors, with the duration of response that you're likely to get with these drugs, that they should always show a much better overall survival benefit rather than the PFS benefit, right? So why is that not the case here? Any thoughts on that? I'm just trying to prick your brains here. That's it, nothing else. So go ahead. I will feel free to shoot.
I'm not really sure about why it's not showing any OS, because generally, we see better OS data with the immunotherapy as compared to, the PFS data. But I hope my seniors would be able to answer this. I'm not very sure.
No, so it was interesting because, see, one of the reasons was about 60% of patients on the trial actually crossed over. So meaning that they received subsequent IO. So that could probably be one reason. And the other is, if you look at even the forest plot here that I put up, usually we see KRAS and NRAS mutant patients actually doing well with immunotherapy, which is not the case here. If you look at this forest plot, the magnitude of benefit in those patients was absolutely minimal. So again, and we always keep talking about MSI and TMB as well. So it will be interesting for us to understand what percentage of these patients had an MSI, apart from MSI high, also had TMB high tumors as well. So because that's the next slide as well, because that's the correlation between all the three, between the MSI, TMB, and PDL1. Because sometimes even if you have an MSI high tumor, if the TMB is low, they may not actually respond that well to IO drugs. So I think that's where it really comes in, and that's why there is still a lot of conjecture as to what should be done. But the one good thing is that we can all take away is in an MSI high tumor, we know conventional chemotherapy doesn't work well. So obviously we are left with a choice of using our immune checkpoint inhibitors right up front. Even with it not showing a great magnitude of overall survival benefit, the PFS benefit is always there. But only time will tell us as to how we actually select out the ideal patient, if there is a perfect biomarker, as far as using all the three biomarkers that are currently available to us. So anybody for this chemo-free regimen, and I'm going to bring in Dr. Tarachand here. Chemo-free regimen in colorectal cancer, is that a dream or a reality now?
Yes, sir. I think it may come very soon, because we can see that many cancers, like which we have never expected, like in lung or breast, that the patient will go in metastatic setting with chemo-free regimen, and now its dream has come true. So it will be seen very soon in the colorectal cancer, because before that immunotherapies, the colorectal cancer had the near equal survival around, along with the lung and breast cancer in a good risk setting, but now they have surpassed because of this chemo-free regimen. So yes, it will be there. I hope that.
All right. Okay. Well, let's bring in Dr. Lalit here. So Lalit, Dr. Lalit, I'll just quickly ask you. Let's say you have a patient with a BRAF mutation. Your first line setting, would you, let's say a patient is young and fit, can tolerate a triplet. Would you look at giving him a triplet in the first line setting? Right-sided BRAF mutant.
And so is it oligometastatic setting or it's...
You can put it down as probably liver-limited metastatic disease and borderline resectable or unresectable disease.
If it is borderline resectable, definitely I would be tempted to use a triplet regimen.
Yeah, fair enough. So I think that's the key take home here is that apart from borderline resectable or unresectable disease is concerned, you only have patients who don't have borderline resectable disease. There's no point in actually using a triplet, even if they have a BRAF mutation, because they have a much poorer prognosis, and you're not improving on the prognosis just by adding a triplet to your targeted agent. So I think that's probably the key take home here from these studies that was recently presented at ESMO as well. So let's move into the next setting, which is the oligometastatic setting that we were all talking about, liver-limited metastatic disease. We know around 80% to 85% are going to present with unresectable disease. Only around 10 to 15% are probably going to present with liver-limited disease, which is resectable. So let me bring in Dr. Divesh here. If you have somebody with a liver-limited metastatic disease which is resectable, what is the role of targeted therapy in those patients? Would you be using even neoadjuvant therapy, or would you go ahead and just do straight surgery on those patients? Liver-limited resectable disease. I know we don't have a surgeon on the panel, but yeah.
So I think I am if the all wild type the KRAS or NRAS, I think I will use with this chemotherapy with this targeted agent, because resectability is more easy, and I think there is more chances of response, so that the R0 resections can be achieved with addition of these the targeted agents.
Okay, no, we're talking about somebody who's already got resectable disease. Okay, fine. That's your point of view. We'll get Dr. Tarachand here as well. Dr. Tara.
Yes, sir. Actually, I was just missing this trial because I was in a liver-limited disease. It was the trial which come 2 years back, I think, 2 years back. That when with the cetuximab, the PFS is shorter, I think. So I will not use the cetuximab in this case in the liver-only disease, and we are going for the surgery near future. And usually in the colorectal, we are seeing that if the PFS is shorter, then OS is not in the favor of that trial. If we go with the sequential in all the trials, I think I can find hardly any trial except the immunotherapies alone.
Correct. Correct. I think that's a key takeaway. I think if you have somebody with resectable disease, do not use targeted agents in those patients. And even a choice, as far as even using systemic therapy prior to surgery in those patients are concerned, I think that needs to be taken as part of a multidisciplinary team management. If somebody is symptomatic for the local disease or presenting with obstruction, then you would go ahead and even do straight surgery upfront and look at doing either a staged metastectomy meaning address the primary first and then look at addressing the liver metastasis as stage mastectomy, or even address it at the same go as well. So, but the situation is probably different if you have somebody who's had therapy in the adjuvant setting and then goes on to develop metastatic disease. Let's say if they have a very short DFI, within 8 months or within a year, if they progress and develop liver-limited metastatic disease, then you're more likely to use systemic therapy there to assess the biology of the disease, to assess the response, and then take a call on surgery in those patients. So I think that's putting it in a nutshell. So, and as far as adding targeted therapy is concerned, definitely somebody with liver-limited unresectable or borderline resectable disease, definitely do a triplet with the addition of targeted therapy. The response rates are much higher, and your conversion rates are to the tune of around 29 to 30%. So I think that's something that we've all known. And you could even do a triplet along with cetuximab as well. Look at the response rates, fantastic response rates. And like I spoke about earlier, early tumor shrinkage and depth of response, much better off with the EGFR inhibitors as opposed to bevacizumab. So let me bring in again Dr. Lalit here. So, let's say, for example, you have somebody with borderline resectable disease. What are the cons of using bevacizumab in those patients? Are you comfortable with using bevacizumab in those patients? Let's say you have somebody with a RAS mutation or a KRAS or an NRAS mutation, but borderline resectable. So you can't use your EGFR inhibitors. You're left with no other choice. Would you use VEGF blockade in those patients?
I would be tempted to use bevacizumab, but then I would be using it with caveats. One is that I would at least give a 4 to 6 weeks bevacizumab free interval before the surgery at least, and even after the surgery, if I'm kind of contemplating giving adjuvant also, then in the immediate post-op period also, for the first cycle or so, probably I would avoid using bevacizumab, and you would have to kind of counsel the patient that after using bevacizumab, the chances of wound healing, the chances of probably development of perforations would be slightly more compared to without using bevacizumab. So probably those would be my considerations.
So Dr. Rohit, your concerns, or do you agree, or would you be tempted to use bevacizumab?
I think the CHIRO5 data, which was presented recently, says that there is definitely a benefit of using bevacizumab. Although they have mentioned caveat is that post-op complications are more, but the chance of resectability also is more. I think 50 versus some 38% or something like that. So I think, it's again going to be a tumor board sort of a decision, but definitely, as I said, 6 weeks, I think is the minimum gap I would give, not 28 days. And, explaining to the patient that this complications could occur, I think I would be tempted.
So yeah, I see, Dr. Rohit, I think the practical issue is that, when you talk about delaying it for 6 weeks, ideally you're only going to give one dose, that's all. And, then your second cycle onwards, you'll have to stop the drug because you can't give it because you'll have to wait for 6 weeks prior to surgery. So effectively you're just talking about delivering one dose of bevacizumab there. And again, there is a risk of delayed wound healing, all these fistula formation, perforation rates are much higher as well. So definitely, it has to be considered, but you'll have to be extremely cautious with that. And as far as somebody with resectable disease is concerned, continuing the targeted agent beyond once you have surgery done, there's no data to that. There's no improvement in survival if you do that. So you don't have to continue it beyond. So I think that's another key take home as well. So and this is something that I was just talking about earlier as well. We look at whether it's a de novo metastatic disease or somebody's gone on to develop metastatic disease after adjuvant treatment, and then you decide on whether you have to do straight surgery or give them systemic therapy and then reassess them for surgery. So let's move on to quickly the maintenance strategies in practice. Dr. Tarachand, what do you do in practice as far as maintenance? Do you do maintenance, no maintenance, maintenance with targeted therapy alone, or targeted therapy with capecitabine? What is your go-to choice of maintenance therapy?
Sir, if usually the patients are biology is fit for the targeted therapies, then I go for the maintenance with the capecitabine plus whatever the anti-EGFR is there or anti-VEGF. Otherwise, usually I don't go, and I give usually the chemo-free interval so that patient can enjoy the quality of life. Okay. Because with the targeted therapy, EFS is quite impressive.
Okay, Dr. Divesh.
I think I am using the maintenance treatment because some patient have fear in my mind. I will stop the drug the disease will recur. So I think in my practice, the 90 to 95% I will discuss for the drug-free holiday. But some patient wants capecitabine only maintenance or cetuximab or bio maintenance. But almost 90 to 95% wants some treatment in form of maintenance. But I'm in my personal view, I am also afraid. Kuch to start rahe, kuch to chalta rahe. If anything can be started, because we will sure that disease will recur in future. We are offering just drug-free holiday because disease will recur in 1 year, 2 years, 6 months, 3 months, and disease will increasing definitely.
Fair enough. So, probably, to summarize, I would probably say, it depends on your depth of response. If you have somebody who's got an ongoing response, you'd definitely be tempted to put them on maintenance. You wouldn't just take them off treatment completely, number one. And number two, as far as just putting them only on capecitabine maintenance, unfortunately, this was a very recent trial that was, again discussed at ESMO as well, which showed that you molecularly stratify them according to the molecular markers and put them on stratified maintenance therapy. And putting them only on capecitabine maintenance did not show any improvement even in PFS. This was not statistically significant. So if at all you're opting for maintenance, it ideally has to be a combination of targeted therapy plus your capecitabine or 5-FU analogs. I think that's probably the one way of looking at it. But then again, a drug-free holiday is very important. If you have somebody who's already had a lot of chemotoxicity and has had a maximum tumor response, then probably yes, it's ideal to sort of give them a treatment break and put them on only on observation and follow-up. So very valid point, Dr. Devesh, I agree. And so this is again, just goes to show you that even if you're using a EGFR inhibitor, you'll have to combine it with the 5-FU analog or capecitabine. So that's probably how the way to go as far as maintenance treatment is concerned. And so anybody for re-challenging, has anybody done that in practice? Dr. Lalit and then Dr. Rohit, do you re-challenge in practice? How many of us actually do even a recheck on our liquid biopsy by checking for the RAS and RAF mutation status at progression? Do we do that in practice? Dr. Lalit and Dr. Rohit.
Well, so liquid biopsy, no, not in routine practice. And re-challenge, yeah, if the PFS has been quite long, and probably I would reconsider. From long, I would mean beyond 6 months.
All right, Dr. Rohit, would you repeat a liquid biopsy at progression? Because there's something which we all talk about is the neo-RAS. Neo-RAS is people can acquire any of these RAS mutations at progression, or they can even lose these mutations at progression. So how important, because we always talk about clonal evolution and then the selection pressure hypothesis, which actually is key for us, because especially if you're looking at re-challenging drugs, then it becomes very important. So do you believe that there is a role for doing a repeat biopsy at progression, or at least a liquid biopsy at progression, CTC cell-free DNA? Or
yes.
Okay. Go
I
ahead.
think we're giving very expensive therapy, and I think we need to be very sure that the mutation is actually present before giving such expensive therapy. So definitely any progression, 100% there will be some biopsy done either liquid or from the primary side.
And I think it's because of this neo-RAS. The incidence of neo-RAS has been reported to be anywhere between 5 to 10%. So, it makes sense for us to even pick out those 5 to 10% of patients. So again, yes, this is what I was talking about. There is a biological rationale for re-challenge. This is the cricket study, which was a phase 2 data, looking at cetuximab re-challenge in the third line, post 2 lines. And yes, it's only phase 2 data, but still something to go by. So, quickly to the third line settings and beyond. So let's say you have somebody who's progressed on a VEGF inhibitor like bevacizumab, for example. Is there a role for using any other VEGF inhibitor? Dr. Tarachan. Somebody who's progressed on a VEGF inhibitor, would you look at using a different VEGF inhibitor in those patients?
Yeah, we can use the, I think one is aflibercept, or you can use that, it's a single agent regorafenib. We can use.
Yeah. Fair enough. Zivapilibacet is something which is not available to us, but ramucirumab is something that we have access to, and that's so we could look at doing that. There is data to do that as well. It has shown a PFS and overall survival advantage as well. But nevertheless, that's something that most of us don't do regularly in practice. because we look at identifying other targets.
So my apologies. You need to
Yep.
conclude your session in 1
Sure,
minute.
sure.
Thank you.
So, just briefly, I'll just pick on, this is something that we were already discussing on as well, the chemo-free regimen, the Beacon study, presented by Axel Grothy et al. So any criticisms on this, Dr. Rohit, I'll bring you in here. Are you convinced with the data? This is phase 3 data, already approved option. Any criticisms about this study?
I
So,
mean,
because we always talk about somebody who's got a BRAF mutation. You don't give them EGFR inhibitors, right? So why are we giving them EGFR inhibitors here? And why design a trial like that?
No, you're technically blocking all the pathways of resistance, and so the entire pathway you're blocking. So I mean, the data seems good, phase 3, but definitely I don't know what the costing of this drugs are going to be.
So interestingly, I mean, like if you look at the rationale, I mean, like I was fortunate enough to interact with Professor Axel Grothy, who was the lead PI of the study. So what he did mention was, when you talk about BRAF plus MEK inhibition, you are blocking the downstream signaling pathways completely. So what happens then is you can have a reconstitutive activation of the EGFR signaling pathway, which is why you are looking at blocking that as well. And again, another criticism of this study is, even if you look at the chemotherapy arm, they ended up giving cetuximab there as well. So they were asked him as to why he did that. So then he said, in order to have a fair comparison in all the 3 arms, which is why they looked at adding cetuximab in that arm as well. So fair enough, the data is out there. There has shown an improvement in overall survival as well. And we don't have access to encorafenib and benimetinib, but we do have access to dabrafenib and tremetinib from Novartis. So I mean, I've had the opportunity to use that for one of my patients. Nevertheless, patient did not do well, went on for around about 6 months, and then progressed. So I think with that, we've come to the end. I'm not going to get into the third line and beyond, but we have a lot of options, TAS 102, and again now with S1 coming into the market as well. And then HER2, we're not going to get into all of that. So with that, I'm going to conclude and say thank you all for your patient listening. Must thank all my panelists for making it such a wonderfully interactive panel discussion. Thank you.
Thank you, Dr. Kripashankar, for a wonderful session, and clearing all the concept of metastatic colorectal cancer and touching every tumor marker and concept. Yes, and thanks to all the panelists for the fruitful contribution. Now we are moving towards the second session, that is the genitourinary cancer. And for this is the pharma-sponsored session by AstraZeneca. So I requested Dr. Nagendra Sharma to moderate the session on consensus on genetic testing and metastatic castration-resistant prostate cancer. So Dr. Nagendra Sharma is the principal consultant, Department of Medical Oncology and Hematology, Max Super Specialty Hospital, Saket, New Delhi. His panelists are Dr. Varun Goyal, Senior Consultant Medical Oncology, Rajiv Gandhi Cancer Institute, Delhi. Dr. Unni S. Pillai, Consultant Medical Oncologist, Cardias Hospital, Kottayam. And Dr. Pankaj Daya, Director Medical Oncology, Dayanand Hospital, Sonikar. Dr. Deepak Bharati, Consultant Medical Oncology, Department of Medical Oncology, SMBDNS Katra. Dr. Vivek Agrawala, Director and Senior Consultant, Department of Medical Oncology, Narayana Super Specialty Hospital, Kolkata. And Dr. Shruti Kate, she is a Consultant and Head Medical Oncology, HCG Manavta Cancer Center, Nasik. So, Dr. Nagendra Sharma, over to you.
Thank you very much, Dr. Chajan, for the invitation and for kind introduction. Before starting, just want to ask whether my slides are visible or whether my voice is audible. Whether my slides are visible?
Yes.
Yeah, Nagendra, it's all visible, and the slides are also visible. You are also audible well. Good evening.
Perfect.
All the panelists, please switch on your camera.
Perfect. Thank you very much. So I think we are having a distinguished set of panelists here, and it doesn't require introduction. I will just, Dr. Tarachandra already called. I think all 6 of us are here. Dr. Varun Goyal, Dr. Pillai.
No, sir, Dr. Varun Goyal is not.
Dr. Varun Goyal is not there. Okay, no issues. Dr. Unni S. Pillai, Dr. Pankaj Daya, right? Dr. Deepak Bharati, Dr. Vivek Agrawal, and Dr. Shruti Kate, right? So I request all my panelists to be online during the panel discussion. And because of the limitation of time, I will come directly to the topic. And the topic today for panel discussion is genetic testing in prostate cancer and management of metastatic CRPC. So where are we as of now? So we have all seen that in last couple of decades, there is a rapid transformation as far as uro-oncology is concerned. there are plethora of options. 2 decades back, there are a handful of drugs. Now, if we tell that we are living in a golden era of advanced prostate cancer management, I don't think that's an overstatement. So prostate cancer, we all have seen that it started, we know that the initially patient will be asymptomatic, then they will go for symptomatic disease. Initially, patient will be non-metastatic, and over a period of time, they will develop metastatic disease. Initially, they will be castration sensitive, and over a period of time, they will develop a state of castration resistant, and which is a downhill course. And over a period of time, like 2 or 3 years down the line, majority of patients will succumb to their illness. This is what we have seen over past many years in our practice, right? So first of all, before going into discussion, what is metastatic CRPC? Can you define? May I ask this question to Dr. Unni S. Pillai? What is your understanding about CRPC? Whether CRPC or HRPC are synonymous?
Hi, Nagendra.
Hello, sir.
Hi, so they are totally different diseases. So, HSPC means the tumor is responsive to your androgen and anti-androgen therapy, ADT. But in CRPC, in spite of you having a castrate level of testosterone, your disease is progressive. It can be a clinical progression, radiological progression, or biochemical progression. So that is when you call that the disease is castration resistant. So that level of testosterone is being defined differently. Probably the most accepted level would be less than 20 nanogram per liter.
I do agree. So actually, my question was whether any difference is there between CRPC and HRPC. I was not asking about hormone-sensitive prostate cancer. So
because once the disease is CRPC, it's a bad disease.
Okay.
It's a bad disease. It's not going to respond as good as your HSPC. So that is the.
I'm not asking about HSPC, Dr. Unni.
No, I'm talking about CRPC. So when the disease becomes CRPC, it's a bad disease.
I do got your point. You're correct only. Dr. Vivek Agarwal, so are they synonymous, or HRPC is equal to CRPC in your understanding about the disease biology?
So you see, these are all semantics, basically, I would say. But in the practical world, CRPCs and HRPCs are same. But if you look into the development of these semantics, so earlier we didn't have much treatment options, and we used to talk about ADT, and once they have crossed ADT, then you talk about them being CRPC. But now you have certain anti-hormonal treatments which are still working in castrate-resistant prostate cancer, like abiraterone, like enzalutamide, and then the newer anti-androgen treatments. So you can probably say that HRPC is that subset within the CRPC which is still not resistant to these hormonal manipulations, apart from and chemotherapy or other forms of treatment are required. But practically these are semantics, and these words are often used interchangeably in discussions and in meetings and all.
I do agree. I do agree with the Dr. Vivek, what you are told, that basically the CRPC is basically disease progression despite of androgen deprivation therapy, which may be surgical or medical castration, may present with either rising PSA, serially, or emergence of a new metastatic site, or the patient is having a progression of pre-existing disease. So this is CRPC. HRPC is usually are looking like a CRPC, but this is a misnomer, misleading. Many times it is dangerous. Reason being, there is a upregulation of androgen receptors, and there is an intratumoral androgen production, because of which they are still, the AR continues to be active. So that's why they cannot be used as synonymous. So the correct definition is metastatic CRPC. Having said that, I will move to the question per se, that what is your preferred drug of choice for first-line metastatic CRPC? So may I ask this to Dr. Pankaj Thea?
Yeah, sure. I would first like to see disease burden of the patient. What is the actual disease burden which the patient is presenting? The patient is having high disease burden, then I would first like to go with chemotherapy followed by the further treatment. But if the disease burden is lower, on the lower side, then I would like to start with hormonal therapies, including enzalutamide or abiraterone, or even depending upon the patient and cost benefit, maybe glutamide or older ADT therapies. So
may I ask Dr. Pankaj, what is your understanding about the disease burden? So when you consider the disease burden is high, and you will go for docetaxel, and when is the disease burden low, you will go for abiraterone and enzalutamide, as you mentioned.
Yeah, disease burden depends upon whether visceral organs are involved or not, and what is the site of bone involvement. If there is some bone involvement which is including more than 4 sites of the spine, or there is heavy disease burden in all the visceral bone sites, then I would label it, and depending upon the patient's symptoms. So it will depend whether disease burden is high or not, and how symptomatic patient is with this kind of disease. If the patient is symptomatic and having some impending failure in the failure leading to maybe spinal compromise, then I would label it as high disease burden.
Absolutely right. I got your point. Dr. Shruti Kate, may I ask you, so how you decide your preferred choice, whether you agree with the other co-panelists or you're having any different take?
So I agree with my panelists. More or less, we all go by this sequence only. And I mean, do you want my answer for the drug of choice for first line?
Right.
Yeah. So if the patient has not received, chemotherapy in the past 1 year, I would want to first choose chemotherapy for a patient who is fit, and then go for the other lines of orally available drugs.
Okay. The patient is not willing for chemotherapy, then what?
Sorry?
How you will decide whether you will go for abiraterone or enzalutamide? Patient is denying for chemotherapy, is not giving consent, even when it's a merit for metastatic CRPC, high volume burden disease. How you just choose abiraterone or enzalutamide in this type of scenario?
Sir, many times the patient could be having diabetes and may not, tolerate a dosage of 5 milligrams twice a day, which is the dose for CRPC. So in this case, you go for enzalutamide. But in other key situations, because we do not have a trial which tells us the sequence of the drugs, and both these drugs have been, the STAMPEDE has shown benefit in high burden disease for abiraterone. So I mean, like, data is there available for both the drugs, but the sequence is not covered in any of the trials, and none of the trials have actually compared them head to head. So I guess we choose it from the clinical profile of the patient, and for me, I would usually keep the steroid thing I would give that a lot of importance, because steroid dose of 10 mg per day may have a lot of implication on the quality of life of the patient.
I got your point. Absolutely right. You are on the target. What I was trying to ask. So may I ask Dr. Pankaj? Dr. Pankaj, how you will decide, like, docetaxel or metoxantrone also is there? So at what dosage you are using in your patients? Are you using the standard 75 milligram per square, or you are going for weekly as per prostate trial?
See, I use it in both the doses, weekly as well as in 21-day schedule. So it depends basically on the patient profile, how fit the patient is, how he tolerates the treatment, and also patient's level of comfort with the traveling, whether he is coming from near or far. So all these things taken into consideration, and patient's choice taken into consideration. We plan for whether it should be weekly or it should be twice, it should be every 21 days. So we give all the options, and then we discuss it with the patient and attending, then we decide.
Absolutely right. So as you can see, the abiraterone, the pre-chemotherapy, the COU A8302 trial, in which abiraterone have shown a median overall survival of 35.3 months as compared to the placebo. Hazard ratio was quite significant, 0.79. And for PREVAIL, for enzalutamide also, this was a landmark trial which have shown that enzalutamide is also in the median overall survival benefit of 35.5 months, right? So although there is no cross-trial comparison, but we have to have a thin line which we have to draw, that when we have to choose a NHS, where you will incline, whether abiraterone followed by enzalutamide will be your option, or enzalutamide followed by abiraterone. So Dr. Vivek Agarwal, can you throw light upon that? What is your take in your clinical practice?
Usually, I start usually with abiraterone. Sorry.
Dr. Vivek, can you unmute yourself, please?
Yeah. Sorry. So what I'm saying is that all these trials were actually pre-HSPC era, when they were not giving anything substantial to the patient in the hormone sensitive setting other than ADT. But the practice has quite changed since last 5 years, when addition of an additional agent, either docetaxel, abiraterone, or enzalutamide has become a standard of care in hormone sensitive prostate cancer. And now we are looking at giving doublet treatment, giving abiraterone plus docetaxel, or docetaxel plus darolutamide, and all those options are coming in for initial treatment. So I think when we are talking about choosing option for CRPC setting, what patient has received in the HSPC setting does make a big difference. And second is the progression-free survival post ADT is also one of the most important factors. Now, if the progression-free survival post ADT is less than 1 year, then these patients are typically not at all good candidates for hormonal manipulations like abiraterone or enzalutamide. And if they have received docetaxel, I would want to sort of go ahead with cabazitaxel instead of going to abiraterone or enzalutamide in the CRPC setting. And if they have again received the docetaxel 2 years ago, 3 years ago, many of us sometimes re-challenge with docetaxel. But again, a re-challenge with docetaxel was addressed in one of the GCAM studies, and it had shown that it does not have a good impact, or doesn't improve overall survival. So those are small points that you have to take. Further, other factors like clinical profile does need to be taken in. And so far as the question of sequence of the hormonal agents, I usually never want to sequence one hormonal agent after another, because retrospective studies have clearly shown that whether you give abiraterone followed by enzalutamide, or enzalutamide followed by abiraterone, both of them have a poor sort of outcome, overall results. And if you switch in either docetaxel or cabazitaxel in between, then you tend to have a better response. Of course, you need to look into the disease burden and the patient clinical profile. And usually what I have felt in my practice is that enzalutamide usually is not a very active drug, and it hardly works in a high disease burden setting, especially in the CRPC. So patients who are in the CRPC, I usually patients, if they have a bulky disease, multiple sites of disease, then usually abiraterone is the way to go. One thing you must also consider is that in this EOU study in the CRPC setting in abiraterone, I think the visceral mets were excluded. So that point also needs to be considered, that if visceral mets are there, then there is a bit lesser data for abiraterone, and you want to sort of prefer docetaxel, or you can prefer enzalutamide also if abiraterone has been used previously. So those are simple points, but it is not such an easy decision. It's a complex decision, and we need to sort of take into account multiple factors, including patients' performance status, their choices, logistic issues, and now we even have other sort of choices for going for genetic testing and MSI testing, and multiple other lines of treatment like lutetium. So we are definitely spoiled for choices.
Absolutely, I do agree. And it's a well articulated answers. Perfectly, you have narrated the answer. So, what percentage of your patient will receive NHA in the first line setting? I think majority of patients will be like who are high volume disease will go for docetaxel based chemotherapy, and those who are not right fit for chemotherapy will be going for newer hormonal drugs, right? So, what is the drug of choice of patient for metastatic in second line? So may I ask this to Dr. Uni? So, what is your second line option? Suppose you have given docetaxel upfront or not given docetaxel upfront. So in both the scenarios, what will be your second line? Dr. Uni, please unmute yourself.
Some connection issue. Am I audible, Nagendra?
Yeah, you're audible, sir.
So the question is, what is the second line choice? No.
Right.
So as Dr. Vivek has already discussed. Most of the patient upfront will end up receiving almost everything. So your next line of treatment depends upon what all the patient has been exposed to and what is left in your hand and what is the performance status of the patient, comorbidities, and how long the patient, what is your DFI you're going to get. So by the time, if you say about CRPC, most of us are using triplet therapy in the first time itself. They will get ADT, chemotherapy, and abiraterone or enzalutamide in the first instance. Then they progress and then they categorize them as, CRPC. So there are very few patients only on ADT nowadays. So second line, when they progress and then they may be exposed to either one of the chemotherapy or one of the other newer anti-androgen therapy, agent like what we have discussed so far. So what is left with after all those things will be lutetium. So if the patient progresses after, say, all this agent, my option will be lutetium. And if we have not used any chemotherapy in the recent past, we will look for a chemotherapy. But what we would like to do is that we'll go for a genomic testing, including an MSI, tumor mutation burden, and a VR splice variant also will be covered if you are doing a comprehensive testing. And then based on that, we take our call. You suppose
absolutely right. I do agree, sir. What your point you have made is absolutely right. What the patient have received in the previous line, what is the performance status, what is the comorbidities, and how is the patient, what DFI you are opting, and how is the molecular reports unfolds.
Yes, and also now the genomics comes into play.
Absolutely,
yes,
I do
your
agree.
TMB, MSI, your BRCA1, BRCA2, everything.
Absolutely, I'll be
and your
getting to that.
XRD also.
Right. So I will not go into deep of that. I'm just asking, we all know about the data that is being published. We know, my purpose of asking this question is what actually we are doing in reality. So what is your ideal drug sequencing pattern in metastatic CRPC? Can you just briefly tell us, because we are running short of time, Dr. Pankaj, can you just tell in what order you will go? Like you have exposed the patient to multiple options. What will be your sequence? Measure times.
My sequence first will be chemotherapy, followed by abiraterone.
Right.
Then down the line, depending upon the response and the time duration, if needed, second line chemotherapy, followed by if needed, then third line treatments.
Right. So if the patient is MSI high, whether you will or TMB also is high, if the patient have done comprehensive genomic profiling, whether your decision will change?
Yes. Yes, because if you had high MSI tumor or you have a high TMB, in the second line CRC testing, you can use Pembro. Pembro, NIPI plus Nivo, whatever, all of them are acceptable choice.
Absolutely right. So what you are told is,
or you have a BRCA positive, you can use olaparib.
Right. So I think all panelists will agree that these are the parameters by which we will decide our regimen sequencing. I will not get into deep of that. So there is, as Dr. Vivek have clearly told, that there is no direct comparison like which drug you will use. So oral survival is in favor of enzalutamide, both in the chemotherapy pre-treated and naive patients, and OS is radical in patients with visceral disease and greater than 75 years of age, and oral survival relatively is better for enzalutamide in patients without visceral disease. So enzalutamide provides a significantly longer time without PSA progression, and enzalutamide provides a significantly better radiographic PFS. So all these comparisons are done in various trials, and the majority of them are retrospective only, and whether abiraterone followed by docetaxel or enzalutamide after docetaxel or abiraterone, all this were tried. So there is a heterogeneity in clinical trials, and it is on the individual, on the merit of the patient, we have to take a decision accordingly. So I will come directly to the genetic testing part. So what percentage of your patients undergo genetic testing? May I ask Dr. Shruti? Are you doing genetic testing for all the patients, and what is the timeline? Like upfront in a hormone-sensitive prostate cancer you will do, whether you will do when the patient develops metastatic CRPC or non-metastatic CRPC, what is the correct time when you're doing this genetic testing?
So I offer genetic testing in the CRPC setting. And I would say maybe 10% of the patients go for it, because that is subject to the the feasibility of going for the therapy linked to that testing. So I would say ultimately only 10% would opt for genetic testing from that point of view.
Right, but you will recommend, you will document everything that we have advised genetic testing.
Yes, I will offer to all CRPCs. I will
So
offer
right
or
now,
document.
open testing available, Dr. Shruti. So we can offer it. It depends. I do agree. It depends where you are practicing, in a government setup or private setup. But even then, we are having open testing available right now, by which majority patient we can expose. Even HRR testing also is available, right? So are you like trying to go for genetic testing in all the patients in your practice?
Yes, so I do offer it to all my patients. Yeah.
Perfect. So we all know these slides. We have seen so many times that the DNA repair genetic aberrations are enriched in patients with regional biochemical recurrent or metastatic prostate cancer. There are plethora options are there now. Right? Profound trial, we all know. BRCA1, BRCA2, ATM was in cohort A, then the rest of the mutations are in cohort B, and there are high likelihood that the patient will develop this type of mutation, and we can offer in the patients who are having merit for that. BRCA2 mutation is usually most frequently altered DNA repair gene in the prostate cancer. So at what stage, which I was trying to ask, at what stage of the patient journey would you recommend performing the HRR testing, BRCA1, BRCA2, ATM testing at the diagnosis or metastasis? So may I ask Dr. Vivek, sir, whether in your practice, how you are doing this testing, and whether you are going for coupon testing or isolated BRCA1, BRCA2 testing or comprehensive genomic profiling, HRR testing?
So, you know, what I usually or do is to offer germline BRCA mutation testing to all my, locally advanced as well as metastatic prostate cancer patients at the diagnosis only. So I offer genetic testing as soon as possible. And regarding the HRR mutation testing, I think, that also probably it is, earlier done is better. Once if I see that the germline mutation is negative, then we offer the HRR mutation testing. And I feel that also should be done as soon as possible because, there is a tissue turnover time, and with the years.
Please unmute yourself, Dr. Vivek, we lost you.
I'm sorry, I think I muted. So once the tissue becomes more and more old, the DNA yield becomes lesser, and it becomes difficult to do the test. So the HRR mutation testing or the somatic testing also should be done as earlier as possible, because then you have higher chance of getting it. Because later on, when the patients are having only bony metastasis, many a times you don't find tissue to get the diagnosis, and then the liquid biopsy for HRR mutation testing is something that is very new and not really explored and validated in most labs. So that is not very reliable currently.
Absolutely right. So whether I'm missing Dr. Deepak Bharti, is he there in the panel? Dr. Deepak Bharti is not there, I guess, right? So I do agree with Dr. Vivek, what you have told, that majority times we have to go for this, and initially it's better to go for germline testing, and then you can decide based on your preferences, right? So at what points in the patient pathway would HRR gene testing take place? Like pros and cons of each, can you tell Dr. Pankaj if you can throw light on that?
Usually, I slightly differ in my practice. I do offer testing for the patients who are in the high risk zone. Patients' family history, patients having family history of breast cancer, younger patients who have been diagnosed before 50 years, or who have a first-line relative with diagnosis of prostate cancer in less than 50 years of age. So we try to, or patient having colorectal cancer, his family history of colorectal cancer. So I try to stratify the patients. Then only I offer germline testing. And based upon the when patient has been diagnosed and patient is on treatment, and then he has failed the treatment, then only I offer for the testing if as per the patient's demand.
It's not demand. Like my question is what, when, how, all these questions have to be answered clearly. It should be clear in our mind. It's if the family history is not there, if all these factors which you mentioned are not there. So in are you not offering this genetic testing?
For the patients who are in the
Sir would request to conclude the session in 1 minute.
Okay. We are running short of time. I will just quickly ask pointed questions. So whether you will do it from the archival tissue or from the fresh biopsy. So may I ask Dr. Unni, just be crisp in your answer, please.
So ideally that has to be on the fresh tissue, because over the time it may accumulate mutation, and so it has to be on a new biopsy whenever possible. If new biopsy is not possible, you can do on archived tissue.
Dr. Vivek, do you agree with the statement just made?
I think conceptually what Dr. Unni has shared is correct, but if you go by the data of the clinical trial, so most of the the tissue most of the taken from the archived tissue only. So you can do either of them, but if a new biopsy can be taken and the patient is enthused for going for new biopsy, then I do not have a issue. I would go ahead with a new biopsy, because conceptually, yes, I would agree that you have newer mutations gathering, and then you can know what are the mutations which are still there and active. But archival tissue is totally acceptable.
Absolutely right. So in PROFOUND trial also, there was a higher prevalence of HRR gene alteration found in the metastatic tissue, that was 31.8%, than from the primary tissue, and there is a slightly higher prevalence of HRR gene alteration was found in the metastatic tumor tissue. So we are running short of time. So I just want to quickly take the opinion, like we are having plasma circulating tumor DNA testing also available right now. We are having germline testing and comprehensive genomic profiling through FoundationOne, or there's so many labs are available right now, and Cooper testing. So what is the pros and cons of each, and in what scenarios you will go for circulating tumor DNA? May I ask this to Dr. Shruti, if you can quickly take this question?
So desperately, if we do not have tissue, neither the archival nor a fresh biopsy, which is possible, then we can do it. But the issue is that if the tumors, especially it happens with the solid tumors, whether the tumor is shedding any DNA into the bloodstream or not. If there is no active circulating DNA, then the testing does not mean anything. And if you get a negative result, then it does not mean that the actually patient is negative. So in the, we may actually get a
we have to remember
is
that the blood testing may miss 50% of the harboring HRR mutations, simply because it will only detect the germline mutations and not those somatic. This is what we want to convey. So if asked to tailor the panel for HRR mutation testing, which gene would you select? You will go for cohort A genes only, because the drug was approved for that only, right? Olaparib for PROFOUND trial, I think we all are aware of that. Whether you will opt for only BRCA1, BRCA2, and ATM is still question mark, right? Dr. Vivek, sir?
I think, I would be happy to go for an extended HRR panel testing, because even in cohort B, although the results were not as impressive, but then, you get an option of treatment, at least if you get the HRR mutation panel. So definitely in today's age, if I'm actually going for a somatic mutation testing, I would go for the entire HRR panel rather than just doing BRCA1, BRCA2, and ATM.
I do agree with your point, but the patient with tumor harboring BRCA1 and BRCA2 alteration appear to derive the greatest benefit as far as this PROFOUND trial was concerned. No doubt about that. And radiographic progression-free survival and overall survival also was favoring olaparib in cohort A especially. So I think we have come to the end of this presentation, and thank you very much for your valuable inputs, and looking forward for symbiotic collaboration in future. Thank you very much, and over to organizers, please.
Thank you.
Thank you.
Thank you.
Thank you, sir. Thank you so much for the interactive panel discussion. And next we move on to the next session of the day, and that is management of MRCC and overview, approaches in first and second line. And for this, I would like to invite Dr. Akhil Kapoor, who is Assistant Professor, Medical Oncology, Tata Memorial Hospital, Varanasi. Over to you, sir.
Thank you. So since we are running slightly behind time, I will try to start off. So we definitely metastatic clear cell RCC management has definitely evolved, and I will be focusing on the clear cell, which constitute around 75 to 80% and associated with VHL mutations most of the times. This is the age-old IMDC criteria, which we still follow, and we do risk grouping on our patients. Favorable 43, intermediate 23, and poorest 8 months. This we have learned by heart from the time we did DM, and we all know the criteria. So this is the latest NCCN guidelines, which clearly says what are the preferred regimens in favorable versus poor and intermediate. So intermediate and poor risk have been clubbed together most of the time in treatment, and favorable risk are clubbed. You can see Pembro plus XZ, Nivo plus Cabo, and Pembro plus lenvatinib are the preferred first-line treatment options, while other regimens like sunitinib, pazopanib, which we tend to utilize till now in most of our patients, it is the now in the other recommended regimens. You can also see cabozantinib generic, which is now available. It is still a category 2B recommendation for favorable risk, while it is a category 1 recommendation for poor intermediate risk. And we tend to utilize a lot of cabozantinib now in our patients if immunotherapy is not feasible. So otherwise, XZ plus Pembro, Nivo plus Cabo, Nivo plus AP, IO plus IO combination, these are the preferred treatment options. So we'll move ahead with this. This is the age-old sunitinib study, which showed significant PFS benefit, 5 versus 11 months over interferons. And then this study established overall survival of more than 2 years in RCC, first time in history. And there was pazopanib study with COMPARE study, which showed that it is non-inferior to sunitinib. And when we see the sunitinib versus pazopanib adverse effects, sunitinib mostly is causing more of HFS and fatigue, while pazopanib is causing more of transaminitis. That is why the PICES study showed us that more patients preferred pazopanib over sunitinib. Then came this famous cabozantinib study, CABOSUN study, which showed that cabozantinib has slight PFS benefit over sunitinib, and this study took intermediate and poorest patients. And the toxicities are higher. Yes, cabozantinib, it is very difficult to utilize full 60 milligram, especially in our patients, where the patients have a low body weight and are compromised and low albumin levels. Then there is the era of IO plus TKI and IO plus IO. So there are multiple choices now. I will see few of them. Why IO plus TKI is one of the preferred options. What is the logic behind this? VEGFR TKIs tend to have immunomodulatory effect by depressing the immune suppressor mechanisms and increasing the immune cell infiltration. So that is why VEGFR TKI appeared to be synergistic to IO agents. That is why they have mostly been combined. This includes EVA plus exitinib, Pembro plus exitinib, and now Pembro plus lenvatinib, apart from Nivo plus cabozantinib. So 4 choices now. If you see this Pembro XZ versus sunitinib study, which is famous Keynote 426 study, we tend to utilize most of this regimen from the longest time, and with primary endpoint of PFS and OS both co-primary endpoint. You can see the complete response rate of 6%, which was first time seen with this regimen. Now we'll see some more regimens where responses are higher even with that, while with sunitinib, only 1 to 2% patients showed CR. If we see the duration of responses, it is around 14 to 15 months, which is highly variable with sunitinib. And if you see this PFS in overall population, 1 year of PFS 46 versus 59%. Further detailed data is available. You can see this is OS data, and OS data is clearly in favor of Pembro plus XZ, and you can see curves separating earlier at the first assessment 2 months, and the curve continues to separate and remain separated. That is why whenever feasible, we try to prefer this combination, IO plus TKI combination in our practice, and it clearly shows that 78% versus 90% patients were alive. And also you can see all the subgroups are getting benefit irrespective of IMDC risk grouping and the PD-L1 positivity. The toxicities, yes, combination is slightly toxic. Diarrhea, hypertension, fatigue is there, but sunitinib also causes significant amount of toxicities. We are well aware of the same, and immune-mediated colitis and transaminitis are present, and it can affect. This is evolumab plus exitinib study. This is also an option, but it is not a very preferred option because of the small study, and you can still see the patients getting benefit over sunitinib and having significant PFS benefit. OS benefit was not proven. Moving further ahead, the other combination of IO plus IO, that is Nivo plus EP, the CheckMate 214 study, where Nivo was utilized 3 mg per kg with 1 mg per kg of ipilimumab 3 weekly for 4 doses, then 2 weekly nivolumab 3 mg per kg. And you can clearly see this study showing, this is the updated data in intermediate and poor risk population. We can clearly see there is a significant OS benefit, and this is a sustained large OS benefit as compared to sunitinib, 26 months versus 47 months at median follow-up of 42 months. So you can clearly see a large survival difference, overall survival difference in intermediate and poor risk patients, and this is very, very huge. And if we see the favorable risk patient, the situation is reverse. That is why Nivo plus Epi is not at all used in favorable risk patients. Sunitinib is better for favorable risk patients as per this data. And this is further updates which have become available. You can clearly see patients sustain benefit with Nivo per Epi for a long time if they get a response. But the problem is that around 50% patients will develop grade 3-4 adverse effects. And how to decide whether to choose IO plus IO versus IO plus TKI, that remains the major question, and that is which we'll see in few subsequent slides. So curves start to separate with immunotherapy at you can clearly see at 24 months. So there is huge separation at this point of time, and there is plateauing for the responses. So after 2 years, the patients who are still responding, it seems that they will continue to respond and remain in the treatment good for a very, very long time. If you see the intermediate and poor risk specifically, at 9 months, curves are separating significantly. While with Pembro plus XZ, you can clearly see the curves separating early at 3 to 4 months, and they remain separated for a long time. So here this is difference, and also in the Nivo plus Epi study, you can clearly see one time even sunitinib is slightly better at 4 to 5 months. This is because some of the fast progressors which is seen with IO plus IO. So there's one point where it seems that the patients will be doing better with sunitinib. So that is a huge point which needs to be understood. We'll see some more points according to him. So overall response rates is 42% with Nivo plus Epi, while it is 55% with Pembro plus XZ. And CR rates are to the tune of 11% with the IO regimen, IO plus IO regimen, and with IO plus TKI, it is 6.5%, as I told earlier. The main important point which prevents us using from Nivo plus Epi in some of the patients, this is the early progressors. Progressive disease, the best response is seen is 25% of the patients, while it is 14 to 15% with Pembro plus XZ, that is any IO plus TKI combination. So patients having higher disease burden tend to do poorly with IO plus IO combination, and there's some hint that PD-L1 low, negative PD-L1 is also able to predict poor responses, but these are just small percentage differences. These are not very strong differences, and these are just hinting us towards selecting some of the best possible treatment. If we see the quality of life data, yes, IO plus IO, the problem is that there is a significant amount of utilization of steroids, because 60% patients, up to 50% patients will actually require steroids for the treatment of immune-related adverse effects. And if you're using IO plus IO, you should be expert in the management of immune-mediated effects. You have a good team of pulmonologists and gastroenterologists who are ready to do colonoscopies and bronchoscopic lavages anytime when it is required. So definitely it is a teamwork which is required, and you should be very cautious and suspect immune-mediated adverse effects in those patients. If we see the quality of life, it seems to be survived better with Nivo plus Epi, while it, as understood, any TKI will cause somewhat more of HFS and other toxicities, leading to somewhat reduction in the quality of life. So toxicities are definitely a different group of toxicities with different combinations. If we see the efficacy, patients having huge disease burden and at risk of higher faster disease progression, who are having rapid tempo of the disease, they should not be chosen for IO plus IO, because there are higher chances of progression in these patients, because up to 25% patients with IO plus IO have progressive disease as the best response. That makes life difficult for a physician. If we see the response rates, you can clearly see it is much higher now with IO plus TKI combination going to the tune of 60%, and it was as low as only 27% with sunitinib alone. Moving further ahead, this is clear data, another trial which is available, Pembro plus Lenva. I will just highlight 1 or 2 points about this. This is again showed significant benefit over sunitinib alone, or also over Lenva plus everolimus, and it has shown a complete response rate of to the tune of 16%. That is a very important point which need to be high. Similarly, there is Nivo plus cabozantinib study, which has also shown very good benefit, and but the complete response rates are to the tune of 8 to 10%. Coming briefly about second line therapies, there are various options when to choose what. That remains depends on the treatment in the first line, comorbidities, and how the patient responded to the first line. For example, if the patient was on sunitinib or pazopanib and the patient fared really well for around 1 year, 1.5 years, 2 years or beyond, we know that TKI is working in this patient, and the next TKI like axitinib or cabozantinib will be better choice. But if a patient is affordable for immunotherapy, nivolumab, that is usually the preferred choice. And this is preferred because the toxicity profile is much better and can be easily tolerated by most of the patients. While cabozantinib is a potent TKI, it is utilized in a large number of patients now. And even if patient has utilized, for example, sunitinib or pazopanib in the first line, now it is feasible to use IO plus TKI combination in the second line. You can go ahead with the same. There is some data for the same as well, though no big trials, but clearly it shows that you can utilize IO plus TKI now if feasible for the same. Everolimus alone is now very rarely used. Lenvatinib plus everolimus, there is a good phase 2 data, and we have also a good experience of utilizing lenvatinib plus everolimus. The key is managing the toxicity and utilizing the doses which are adjustable. For example, if you are using lenva plus evro combination, you need to start at lower doses. For example, 10 milligram of lenva, and then increase the doses to 14 or 18, whatever is the best, and 5 milligram of everolimus, or initially OD, and then later you can switch to BD doses as well. So the key is to have a good upstaging of the doses for lenvatinib plus everolimus. So if, for example, if patient is on IO plus IO in the first line, then you can definitely use drugs like cabozantinib or lenvatinib or lenva plus evro in the second line. If patient has utilized sunitinib or pazopanib or cabozantinib in the first line, then you can utilize immunotherapy. Also, you can utilize, for example, if patient has utilized which can be, the choices depend on the toxicity profile, the comorbidities of the patients, and how we select the patients. So with this, I suggest that the risk group, tumor burden, sites of metastasis, the rapidity of responses which are required if patient is receiving second line treatment, the responses to the previous treatment, all these are very important to assess, and that will help us in deciding the next line of the treatment. So with this, I would like to conclude here. Thank you and greetings from team.
So Akhil, is there any role of dose modification of nivolumab plus cabozantinib in a not affordable patient, low dose nivolumab?
So in real practice, a lot of dose modifications goes on. Low dose immunotherapy is utilized actually a lot in real practice. We tend to utilize it when the patient is not feasible for the full doses or 3 mg per kg doses, and the schedule is highly variable. Sometimes 40 mg, sometimes 100 mg, whatever is feasible. But the key is that you should utilize best possible combination and invest what is best for the patients. So I completely agree. There will be no randomized data for the same, but it seems that whatever is best for the patient, we try to do the same.
Thank you for a wonderful and nice presentation. Now the next is the panel discussion on metastatic renal cell carcinoma, which will be moderated by Dr. T.P. Sahu. He is a senior consultant in medical oncology at Silverline Hospital. So I invite Dr. T.P. Sahu for the moderation. His esteemed panelists are Dr. Ankit Agarwal, consultant medical oncology, Gitanjali Hospital, Udaipur; Dr. Renu Mishra, assistant professor, Gitanjali Medical College and Hospital, Udaipur; Dr. Mukesh Rulania, He is an assistant professor, Department of Medical Oncology and Bone Marrow Transplant, SMS Hospital, Jaipur. Dr. Trivikram Rao, consultant medical oncologist, American Oncology Institute, Hisar. Dr. Manu Prasad, associate professor, Department of Clinical Hematology and Medical Oncology, Malabar Cancer Center, Thalestri, Kerala. So, Dr.
Sir, can you please 1 minute? So Dr. Trivikram sir is not joined. For a replacement is a Dr. Bhavesh Poladia in a Namakal.
Okay. So I welcome Dr. Bhavesh Poladia. He's my dear senior also from alma mater, and he will be the panelist in the place of Dr. Trivikram.
Hi, good evening. My slides are visible and I'm audible. That's for sure.
Yes, sir. Yes, sir.
Yeah. So I'm replacing the initial, the original moderator for some personal tragedy which has happened. So let's jump to the topic. We are already 10 minutes behind schedule, and let's see that in the next 30 minutes what we can do. And most of them has been spoken already by Akhil. But what I want to do is what practically happens and how do we integrate the evidence what we have to the bedside. That's what I'm going to do in the next 25 to 30 minutes. So let's have a case and then discuss the case. It's a 50-year-old RCC, clear cell variety, resected 4 years ago, and there was no evidence of metastasis at that point of time. The imaging had multiple, now the patient has multiple pulmonary nodules and bone lesions. And the biopsy of the lung also showed a RCC, which is clear cell variety. And the creatinine is within normal limits. The ECOG PS is the well-preserved male patient. And there was a painful spinal met, so he underwent radiotherapy to the painful spinal metastasis site. This is the TLC. The TLC is borderline and not beyond 11,000, 10,300. The hemoglobin is 13. The neutrophils are 83% higher than the normal. The platelets is 5.2. The corrected calcium is within normal limits. So, Dr. Ankit, first to start off with, what do you do in your practice? Do you use the IMDC or do you use the MSKCC till now?
So we are using the IMDC risk stratification. We use neutrophil count and the platelet count also. We include that in our routine practice. We do that, sir, routinely.
So it's IMDC for you. Okay.
Yes, sir. Yes, sir.
Anyone in the panel uses MSKCC, because you would still file a lot of publications still quoting the MSKCC. It's not that that is not done, but in the present era, most of us have shifted to IMDC, and probably all of us feel that this looks a little more appropriate risk categorization per module. Anyone who use still MSKCC? No? Okay. So the basic difference between the IMDC and MSKCC, all of us know and rightly pointed out, the IMDC looks much more easier to do. You have lesser, one test more, a CBC and a clinical examination, and the history would be sufficient for IMDC apart from the calcium. That's what is the thing. You need another extra lactate dehydrogenase for the MSKCC, while the neutrophil count and the platelets are not considered. The basic point is, when you have a high neutrophil and platelets, that just give a poorer prognostic criteria, and that is why probably these factors do matter, and this does point out to a high risk factor. And the interpretation, all of us know, 0 to 0, 1 to 2, and more than 3. Okay, so I'll skip this and come to the question in concern. Dr. Renu, let's assume that this patient would have come as upfront clear cell variety of metastatic cancer where the nephrectomy has not been done. Would you, in your practice, do the debulking nephrectomy? Number one. And if yes, which are the patients you do? Or number two, you do not believe in that because most of the trials have shown that once it's the metastatic, it does not make a difference to go for a local nephrectomy.
Sir, we still suggest nephrectomy only in when there is very minimal extrarenal disease and favorable features are there. Then
so you are okay. So you are considering your nephrectomy in let's say oligometastatic type of setting. That's what I presume you told us. And you are also looking at for the favorable risk. You would not be looking at beyond that. Okay.
Yes.
Do you have any trial? Let's say, Dr. Bhavesh, do you agree to her, or do you feel that once it's a metastatic, it's a systemic therapy, and you would prefer to consider a nephrectomy at a later point, and just probably would not do it upfront? What is your practice, Bhavesh?
So now we have actually given up on surgeries. And
Okay.
most of the patients we are trying to metastatic RCC, we try to keep them only on therapy rather than going for surgery. Surgery is only we send the patient if the patient is having a very painful growth at the lumbar area of the kidney, or the patient is having uncontrolled hematuria which is not getting controlled. So for any symptomatic treatment, definitely we refer them for the surgery. But otherwise, we ask them to directly go on the therapy itself.
Even in the low risk, you would not consider with a very low disease burden?
Very select patient. Most of them will be on therapy.
Mukesh, any difference of opinion, or do you just agree with Renu, or do you go a little bit towards Bhavesh, who's more pointing towards a systemic therapy approach predominantly?
Sir, we doing cytoreductive nephrectomy regularly. The patient have IMDC reach stratification and 0 or 1 with no brain, bony and liver metastasis, and patient have ECOG performance status 0 and 1. Then we definitely consider cytoreductive nephrectomy.
Okay, so I'll come to that. Just a quick, Dr. Manu, anything different from what has been told, or do you consider and believe in the concept of delayed nephrectomy?
Yes, sir. Two situations we usually come across in the clinic. One is oligometastatic renal cell cancer. So if the number of metastasis sites are much less, and if they also can be addressed by a surgery or an SBRT, we generally go for a curative treatment approach with nephrectomy plus resection of the metastasis. If it's not resectable, we go for SBRT or some other form of local treatment. That is one scenario. Another thing, as previously I've discussed, if there is extensive metastasis, generally we do not consider for cytoreductive nephrectomy, except in very select patients with good risk disease, very limited metastasis, good performance status. In select group, we may consider.
Dr. Manu, the point which you told first does make a difference, that if you are able to achieve R0 and able to do a metastectomy, you couldn't discuss with it, although the data would be still arguable. But yes, we can consider that. The second point that I'm coming through to the panel, which I want to just conclude on this part before I go to the evidences, the panel believes strongly that they could use, not for all, but for little bit of selective patients. Dr. Mukesh was the one who used it for most of his patients, even for the category 1 of the risk factor 1. But there is data to some effect. I totally agree, Mukesh, that you may do it. But the stronger data is towards probably no nephrectomy as a rule. And you should only do it in selective patients, as most of the panels have told. The data which is for cytoreductive nephrectomy was the interferon era. And if you look at in the era, there are two trials which are quoted, the Carmina and the Certine. The Carmina is the trial which really moved away the doctors away from the cytoreductive nephrectomy. But I just want to put one thing. The concept of delayed nephrectomy is something we should be considering, which I feel that was told in the Certine. A smaller data could not accrue, could not recruit as much the trial had initially sought for. But one thing that comes up is that point number 1, in an intermediate and high risk, there is no data to tell you that the addition of cytoreductive nephrectomy, except for in locally painful or hematuria massive, as Bhavesh told, it helps. It actually, the intermediate also, it does not help much. But yes, there is some data for the one risk factor which it tells you that probably you can go ahead. But as a rule, if it is low risk, you may go for it. But the Certine is one trial which has shown that if you do a systemic therapy, let's say for 3 months, 6 months or something, here it was 3 months, and then in the responsive patient, you do a nephrectomy, you probably achieve much more survival. And even the small subset analysis from the Carmina also told us that. So anyone in this panel practices delayed nephrectomy? A quick raise of hand and then I move on. No? Okay. I think, yeah, please. Manu, you wanted to come in?
No, sir. No, sir.
Okay, I think there is a good concept towards that, and there is more than one data set which points towards a delayed nephrectomy. If one is in doubt on baseline, then probably if the patient sustains a good response, although there is a metastatic disease, you may go ahead for a responding patient. So let's move on and come to where we are, medical oncologists, all of us. And this is now the same patient. What would you recommend now? Can I start with Dr. Mukesh first, and then Ankit, and then Dr. Rin? What is your go-to therapy for this patient? Finances, not a problem. So let us first discuss the non-financial toxicity. There is no problem with finances.
So, because sir, patient is asymptomatic, so I consider IO combination, neo with VP.
Okay. So because patient is asymptomatic, so I'll stop here and ask the panel a question. Dr. Renu, have you considered active surveillance for a patient of asymptomatic advanced RCC?
So active surveillance is definitely an option, but this patient is having symptomatic bone mets. So
that was taken care of with radiotherapy. And now the patient, when he came to you post radiotherapy, does not have any pain. Okay, I've lost Renu. Is Renu there?
No. Yes, sir. Yes, sir.
So now it's asymptomatic patient. What is your take? Have you ever practiced active surveillance?
So frankly, we have not in a metastatic patient. But yes, there is some data for like favorable groups with oligomets, like less than 2 organ mets. We can offer active surveillance.
Okay, I'll come to that in a minute. I'll take this as active surveillance first. Bhavesh, have you ever practiced active surveillance? Or anyone in the panel who has done that?
No, sir. No.
Okay.
Not done.
No. Are you aware that NCCN puts it as one of the options?
Yes.
Okay. Actually, this data set comes from I think it is, if I'm around 450, 500 patient prospective data set. Although there is only 2 data set for this, one was a 50 odd patient based on which a larger data set was taken, and there is no linkage between a low risk and a high risk. Actually, in the data set, it was felt that patient who was on active surveillance, even the high risk group also who were there, who are asymptomatic, also survived longer. So basically, the point which the trial concluded was they are probably of a different genetic uptake, which we need to identify. And these patients actually do even good, even if they are high risk. So that point, Renu, is to be taken with in a data. But what I'm telling you, none of us do that. But I think after reading the data, I feel convinced if I was 75, 80 years, asymptomatic, and the family understands and the consent is well taken, I think we should be start to discuss these things. That's the only point which I wanted. Tell Renu, come on. What is your take? Because Mukesh told it is an IO for it. What is your take on this patient?
Yes, sir, I agree. Because the patient has no symptoms as such. The pain part has been taken care with RT. And
this is the risk categorization. Here I have a high neutrophil. Here I have a high platelets.
So this is saying
it is intermediate.
Okay.
So now please take it on. So what is your choice?
So for intermediate risk, IO plus IO is a.
So for you, it's also IO. Ankit, your drug of choice?
Sir, I would consider IO plus TKI actually.
Which IO, which TKI?
So pembrolizumab with axitinib. I have although very limited experience, but I've used it in only one patient. So I'm comfortable with that.
Fair enough. So basically, conceptually you want to go for a IO plus TKI, and you would prefer axitinib or pembro because of the experience which you have gained. Let it be small. All of us know that all of us do not have large number of patients except for large institutes probably. But my point is, if I go for a IO and TKI, Bhavesh, you can come in and take it. Why would I not go for a pembrolizumab and a lenvatinib? The responses are more. Why should I not go for it? And if I look at the data, this looks the most attractive data set actually. Although I agree with Ankit that the Axi Pembro has been there for long, and it is not a bad data set if you believe in the TKI and IO concept. Dr. Bhavesh.
So, sir, only thing which is attractive towards IO-IO combination is the follow-up data, which is longest. and once the patient goes into the CR, probably those patients are the one who are always going to, for a very long time, almost for 5 years, 10 years data is there.
But are you not worried about the progressive diseases?
Yes,
huge
so
amount of
I was coming to that this is a good part, but the bad part is almost like 1/4 of the patients are going to progress. So considering that, my choice would be Len plus Pembro, which has maximum CR rates. So we are basically, that is CR rate is better than even IO combination. So if we are focusing on CR, that is the best one.
Okay. So again, I get IO TKI 2 versus IO 2. So Manu, you are the tiebreaker one. So what would you do in this situation? What is your go-to combination?
Sir, I also prefer IO plus TK, and generally we use pembrolizumab and lenvatinib. That is just, I'm more comfortable with the lenvatinib than axitinib, so that is the reason.
Are you concerned about the toxicity? Are you comfortable with that? Even on a numerical, although they look similar, you look at the last but one, the safety, the data, it is 72% versus 67%. I'm not telling it's very toxic, but the data is that it's numerically higher. But there is a higher CR rates, which I told, but it is like crunching the data. The basic concept is there is a good response rate that comes with the TKIO, much bigger than what you get in IO. The progressions are less, the toxicity is higher. So you are buying a better drug with a higher toxicity. So how has been your experience with that?
Sir, I don't have any experience with IO plus IO in RCC. I mainly used IO plus TK. And compared to axitinib, I felt lenvatinib is better tolerated when we reduce the dose. So my experience with axitinib was not very good. So for the practical reasons, I prefer Pembro plus Len, and also higher CR and response rates.
Okay, fair. Anyone in the panel wants to come in and volunteer for in the low risk? Would you go for a single agent sunitinib or a pazopanib type, or would you go for a IO-TKI? Although the approvals are there pan across.
So, Sir Bhavesh here. I think in favorable also, Len plus Pembro is a good choice. Just wanted to make one comment with the previous point regarding the safety data. So the recommended dose of Len is 20 milligram in Len plus Pembro. In practice, we usually don't reach to that. So we
start off with a much lower and go on. Okay.
So probably we can come down on the safety data. I mean, safety data 72% with 20, yes. But with the dose, what we use 10 milligram or 14 milligram or 18, it may not reach that much.
So quickly, Bhavesh, I will counter you with the fact that this is one subgroup, the good risk, which does not have OS benefit. So I have a drug which is nearly costing me nothing, or it is costing me 2,000-3,000 rupees, versus a drug which will cost me 4-5 lakhs, probably without, or 3 lakhs, 4 lakhs, without any much additional benefit on OS for this good risk category. So would it not be fair if someone wants to do it and do a IO in the second line single agent? Is it not fair to him? Because I'm not getting that OS advantage.
So fair enough, because if we get the best PFS, most of the patient even don't reach second or third line. So once they start progressing, they may not reach second or third line, definitely not. So I want to get that PFS, which is the maximum in the first line.
Okay, Dr. Mukesh, I'll conclude what I feel about it when I do this first line. Dr. Mukesh, quickly, if the patient is not affordable in Indian scenario, IO is out of the question. I heard my previous speaker talking about cabozantinib, his go-to drug. Do you do that, or do you still go for a combination, probably a everolimus lenvatinib, which is used in second line? Or do you go for a sunitinib, although it is for the good risk, especially not for our intermediate, not for the high risk? What is your take on that?
Currently in our setting, government settings, many patients have financial issue. So in maximum number of patients, we utilize sunitinib in first line settings, and some patients
even in high risk.
Even in high risk.
Okay, fair enough.
Yeah.
Renu, your take on this? Do you agree to him, or do you think that if I cannot use IO and if I have to use a TK, I'll go for cabozantinib?
Theoretically, this is true, but practically in clinical practice, a lot of our patients are from the government scheme, and we also end up using sunitinib more than cabozantinib.
Okay. So anyone, Manu or Bhavesh, what is your take? Is it cabozantinib or is it sunitinib, as others have stated?
नहीं होगा रे,
Sir, in
सर्दी में
fact,
कहाँ खराब होगा?
I have seen patient not tolerating even cabozantinib in the first line, even at 40 milligram.
That's fine.
So,
But what is your go-to drug?
So usually I would like to go for sunitinib,
Okay,
if they can tolerate, and that is 2 week on and 1 week off regimen.
okay. So Manu, quickly, and someone can mute. There's a lot of disturbance in the background.
Yeah, I also practice in the similar ways, right? I use either sunitinib or pasopanib in the first line setting, especially when there are cost constraints.
What the data tells us, there's only one data set, the Cabosan, which looked at the high and intermediate risk of cabozantinib versus sunitinib. The criticism, it's a very small data set of around 100 odd patients. It's a phase 2 data. The PFS was superior for the cabozantinib, although the OS was no different. But that is what I think our previous speaker adhered to, that if there is a high risk, and you have a drug which is, although the data can be criticized, the cabozantinib appeared superior in terms of PFS. So that is how the data set has come. But I totally take your point that you do not have a level 1 high quality data to tell that cabozantinib is superior to sunitinib. I think all of us agree to that. The second point, what I feel in the first line is, the IO-IO combination has to be chosen very, very carefully. There are a lot of progressors that you have to be very, very careful. It's a huge progression. The IO-TKI is probably the way to go ahead in most of the patient. The responses are the best, and the median survival are probably much better. Although the IO-IO, the plateauing of the data is there after 3 to 4 years. That's already there in responders, as people have spoken. So with that, and lastly, I totally little bit differ from Bhavesh. I although would discuss with a patient, but in a good risk, I will probably not push for an IO in the first line, because the data set across trials have shown that you do not have much difference on the survival. It's not one, but every trial has shown us that, including the IO-IO data. So now moving on quickly, we have 5 to 7 minutes. How do you choose your second line? Can you come in, Ankit? How do you choose your second line? And what is your way, how you go for a second line treatment?
Right, sir. So we take that this patient had received IO plus TKI, for example. Recurrence had 4 months.
And the patient recurred after stopping IO and took IO for 2 years. And then the patient recurred after 4 months. Because the patient told, "Ab bahut ho gaya," although it's a very untypical situation. That's point number 1. Or the patient progresses during IO-TKI combination. There are 2 scenarios which I want you to answer.
Right. So if the patient progresses during IO-TKI, what I would like to prefer is a TKI as a second line. I would not consider if the patient has taken axitinib. The second line I will prefer it as will be cabozantinib. If the patient's the cabozantinib would be my preferred second line choice as a TKI.
Okay. In the other scenario also, a cabozantinib would also come in.
Yes, sir.
Okay. Dr. Mukesh, your quick answer to this. Second line IO-TKI given, you are in a government setup, the patient has come to you, believing you that you will not be like us private practitioners. So what will you do?
So if patient taken TKI at first line, then
TKI, sunitinib, it has taken axitinib and pembro.
Yeah, only if patient taken only TKI at first line.
No, IO plus
IO with TKI. Then we consider second line as a TKI, second TKI, like if patient utilize sunitinib or cabozantinib, then consider cabozantinib in second line.
Dr. Bhavesh, I'll ask you a different question. Have you ever considered adding the IO to a person who has not done well to the first line IO regimen?
Sir, I have not done personally, but I have actually discussed over the national and international forums. And some authors, some actually practitioners are using IO combination in second line after failure of IO-TKI, and they are getting some responses also.
Okay. So Renu, have you used, and what do you think? Because people have just forgotten the lenvatinib and the combination of everolimus, and that is the data. If you look at the data set for here, it is one of the best data set for responses. It is the highest, 43%. That's what you would get. So in a patient, would you not consider this a lenva everolimus as the second line? Because people are moving towards cabozantinib. We have the data for Meteor, but look at the data from HOPE 205. that is probably as good or probably little better than the cabozantinib data. Dr. Renu, what is your take on that? If she is not there, Manu, can you come in for that?
So, the options that I'll be considering will be either cabozantinib, or if the patient is not exposed to lenvatinib, len plus everolimus. So that has definitely shown a PFS benefit, but there is no proven or statistically significant OS benefit. But it is a feasible option in second line setting, though we may need to reduce the doses of all these drugs based on the tolerance. We have used it in some patients and it has worked. Definitely PFS benefit.
All said and done, that's how we normally do. I will just show you the data of IO which Bhavesh spoke about, but you have to look at the HIF2 alpha inhibitor. It is coming probably in a good time, and probably in 2-3 years we would have this in the regimen of armamentarium of second line. The belzutifan, if you look at the data, is impressive, and I do find if you cross trials, if you compare it, even in the third line, it has and prior immune checkpoint inhibitor, the responses are impressive 20-30%. The median PFS is around beyond than a year. So I'm not telling it's ready for prime time, but you would see lot of trials now including this into the data in combination with others. Even IO with this combination also is coming in. So this is the data, Bhavesh. There were 2 or 3 data. If you look at and do not have a response, they have added the EP to the Nivo, and probably the response are not great. It's around 10%, 4%, 5%, and the CRs are 0 actually. So it's not a very impressive data set across 3 trials, pointing towards that you probably will not achieve much. That is what it is. But yes, it's an option you may discuss. But I think the combination of the everolimus and the lenva or the cabozantinib will score over than looking at the data and the cost and the benefit which they give. So if I look into and go to the third line, I have used my lenvatinib and the pembrolizumab. I've used everolimus. I've used the axitinib. So Dr. Ankit, what is your third line? Patient is fit and he tells you, boss, mereko aur bhi jeena hai mereko. So what would you do?
Recurrence is at 11 months now.
Yeah, recurrence
Right,
is 11
sir.
months. A good impressive
doing
11 months.
Good,
Yeah, he's
good
doing well.
number. So third line, what if lenvatinib has been already used? I still have other TKIs. I would still again discuss about one more thing. I will discuss about nivolumab. I will still consider using.
So you'll reuse and re-challenge, although it has
Yes.
progressed within 4 months. Of the
Yes,
first
sir.
line TKI.
Yes,
Okay.
his ECOG is good. So TKI.
So you
with
want to give that
probably-
once again in TKI. Okay,
Yes,
fair.
sir.
Manu, will you do a TKI? Will you do an immune checkpoint if the patient has progressed within 4 months of the starting of the first line TKI? Immune checkpoint.
Yes, sir. Less likely if the DFS is
Less
very
likely.
short.
Bhavesh,
Likely that
what is your go-to? What is your go-to drug?
So here it will be cabozantinib maybe.
Okay, so that is one option, but there is one trial which you have in the third line, and this is the TiVo. The TiVo-3 and the tivozanib versus sorafenib. If you look at it, this is one data which looks better. You would not expect a lot of CRs in such a setting of third line with the TKI. You don't get it in first line, so but it looks superior. And this is one drug. I don't know. I've not used it, but data-wise, this is one option which is there. Cabozantinib, you have patients in third line which are responding. You also can use everything that you have not used in second line, which I showed. Immune checkpoint, Dr. Ankit, to be very fair, if it's progressed within 4 months, I'll be very, very skeptical, because the progressors and hyper progressors, I'll be very, very little skeptical.
Sir, after stopping 2 years, he has progressed in 4 months.
No. If I is a progress during treatment in 4 months.
Okay.
The other one, yes. I'll take it, and I'll definitely jump towards it one day. So this is the if you look at the TiVo-3 trial, even the prior IO group also, it has done better than sorafenib. So we have forgotten sorafenib, but I have one patient on sorafenib, luckily going on after 10 years in CR, in a metastatic multiply. It's one patient I wanted to do something for him and find out why he did so well. So last quick 1 minute and we stop. Anyone believes in adjuvant immune checkpoint in RCC? Ankit, yes, no, quick.
Sorry, I didn't get your question. I'm so sorry.
Adjuvant immune checkpoint inhibitors in RCC. Are you
Yes, sir.
convinced of the Keynote 564?
So stage 2 and stage 3, pembrolizumab.
You would convert.
Yes, sir.
Okay. Bhavesh, yes, no.
Yes.
Mukesh, yes, no.
No, sir, we are not utilizing currently. No.
Okay. Manu, yes, no.
No, sir. There is no OS benefit proven. Another agent has was not found to be effective.
So there is no OS benefit. So you will wait for the OS and then jump to it. Renu, you are there?
Yes, yes, sir.
Do you believe in the keynote 564?
Yes, yes, I do.
You believe. So 3:2, and I would be the person I still would like to wait like Manu to wait for the further data, because I feel it's a costly drug. One more thing which I have, look at the hazards 0.68. I'm not telling the data is not good. The data is very good actually. And a lot of my seniors and a lot of friends do use it, and there's nothing wrong in that. But for hazards 0.68, look at the sunitinib hazards for the S-track. It's around 0.7. The only point we took out sunitinib in this is we just did not achieve a OS benefit. So will this 564 not achieve OS benefit? If it does not, I feel again, people like Manu and me will jump and tell you, see, we told you to wait, and you just did not wait. So I think at this point we should discuss and also tell the patient that OS benefit is still immature and we would like to have a more mature data. Other drugs I don't think is there. The sunitinib data, to be fair, had more toxicity, but if you look at the sunitinib data, it only included the high risk patient. In the Pembro, you had a mixed bag. Also, you had a M1 positive patients also. So with that, I think we have covered the armamentarium of RCC. And if anything is there for anyone to speak, he or she can just speak out. Otherwise, I would like to thank the organizers, and I hope people have learned something. And at least I learned a lot of things when I prepared this slides. Thank you.
Thank you, sir.
Thank you, sir. Thanks a lot.
Yeah, I'll just get it back to the organizers to take it forward.
Thank you, sir. Thank you so much. And next we move on to the pharma session sponsored by Merck. And for this, I would like to invite Dr. Asim Samar, who is Senior Consultant Medical Oncology at Bhagwan Mahavir Cancer Hospital, Jaipur. And he's going to speak on choosing right immunotherapy in advanced urothelial cancers for optimum patient benefit. Over to you, sir.
Okay, thank you, team, Dr. Tarachand, and thank you organizers, and thank you, Mark, for choosing me as a speaker for your session. So I would like to share my screen. So is this visible to you all?
Yes, sir. Just
Okay.
make it full screen, sir.
Yeah, I have made it. So it is moving now.
No, sir. It's not in a full screen mode.
From my side, it is full screen.
Sir, can I run from my side?
Yeah. You can do that.
Asim, what you can do is just just get out of that and redo it, and you'll get. Your slide will be already full screen if you will just go to.
Yeah.
Just share once again.
So just a minute now, sir.
Just share once again.
Yeah, I would do share once again, right?
Just reshare.
Now I will do the full screen. Is it moving now, sir?
No. Sorry,
No, sir.
let them. Okay, chalo.
Okay. So thank you, Dr. TP Sahu, sir. You stayed till the last presentation, and I was enjoying your presentation. And actually, I am looking after this GUGY diseases. So renal disease is my domain, and I learned a lot of things from your presentation and the moderation. And now, can you run the slides, Gitika? Hello. Yeah, this session is sponsored by Merck. Right. So we'll go further. You just run through the slides. So as we all know, okay, it's okay. As we all know, that's in the urothelial cancer treatment spectrum, the first was the cisplatin, which came into the world, and it has made some good, you can say, the treatment paradigm shift. And now after the 1970, we would expecting like the disease will be curing and patient will have a good effects. So for the 10 years further, the no player was there in between. So cisplatin was the king, and still it is a king, and it is a pivotal drug. And 1980, they discovered the multi-modality, multi-drug treatment, AMVEC, but we all know it is very toxic regimen. And I have doubt like somebody is practicing in the India. Then after say about 20 years after, they discovered the platinum-based doublets chemotherapy, which has made some impact on the treatment of the urothelial cancer. Then after 8 years, gemcitabine came into the picture, and that time it was being used for the lung cancer, and they have tried in the urothelial cancer also, and the results were increasing. After 10 or 11 years, 9 years, the era has changed for us. So in 2015, they were discovering this pembrolizumab or immunotherapy in the other cancers, like in the lung cancer, and slowly they moved towards the urothelial cancer also. So pembrolizumab and atezolizumab was FDA approved in this situation. And then you may see like in the avelumab has come in 2021 and approved as a monotherapy for the first-line maintenance treatment of adult patients with locally advanced or metastatic urothelial cancer who are progression-free following platinum-based chemotherapy. And we all know like urothelial cancer has a not very great prognosis once they are in an advanced stage or in the metastatic stage. But now we have one immunotherapy which can make some difference in the patient's life. So it is important. Next, please. Okay, so this is an important slide which we practically face every day. Like if you start 100 patient treatment on one day, so almost 70 or 65% patient do not take the second line treatment. Why? Because patient progress so fast and their life is they may not be in the shape of receiving the second line therapy. Or you can see like the disease is occurs in the advanced age group, and they are not only 35%, maybe the 1/3 of the patient are able to take the second line chemotherapy. So this is the case. Next, please. Here you can see like we generally decide treatment based upon the performance status, how their cardiac functions works, or their general condition is how much good or bad. We generally, medical oncologists do the performance status assessment according to ECOG performance status. So we generally give the chemotherapy to the ECOG PS1 and 2. Renal functions are important to look at because this kidney cancer patient or the urothelial cancer, kidney cancer are a separate thing, but urothelial cancer patient generally have some disturbances, maybe because of their age, comorbidity, or the disease itself. There is a dysfunction in the renal function. Sometimes there is hydronephrosis which is causing or dropping the renal function. So we need to decide which platinum agent we need to take it. And sometimes patient may have some neuropathy because of some like diabetes or some other diseases. So again, we need to check it, like patient will go for your doublet chemotherapy or not, or age is the we know all that age is the prime factor to decide upon, and age affects all the above mentioned three parameters. So almost 70% patient may go for the cisplatin based chemotherapy, but 30 to 50% patient are ineligible. So out of them, if you say like 50% or 30% patient are ineligible, then 75% patient can be offered as a carboplatinum based chemotherapy. Next, please. So this is the this paper and poster is actually it is a poster, and it is very beloved poster for the Tata students. It was presented by Dr. Sudeep Gupta, and they have author's conclusion was based on the survey, any patient with metastatic urothelial cancer meeting one of the following 5 parameters should be considered as a platinum ineligible. Like if the PS score is more than 3 and more than 3, creatinine clearance is less than 30 ml per minute, peripheral neuropathy grade 2 or more, NYHA heart failure class 3 or ECOG PS2 or creatinine clearance less than 30. If PS score is 2 but the creatinine clearance is low, then they are the ineligible for the cisplatin based chemotherapy. So next, please. So these are the parameter. These were the parameter on which we can base our decision for treating the patient. So regulatory updates for PD-L1 and PD-1 and PD-L1 therapy in advanced cisplatin in ineligible urothelial cancer. Pembrolizumab is indicated for treating patients with locally advanced metastatic urothelial cancer, not eligible for cisplatin containing chemotherapy, whose tumor expresses PD-L1. And for, you see, like in the lung cancer also, or in other cancer also, pembrolizumab trial have requirement of giving the drug is CPS score more than 10. Only if they are done with the FDA approved test, and if it is more than 10, only then pembrolizumab has good impact. Otherwise, there is no benefit of giving this pembrolizumab. So it was a criteria. And in patient not eligible for any platinum containing chemotherapy, regardless of the PD-L1 status. Atezolizumab is indicated for treating patient. The paradigm are almost same, but the thing is that tumor infiltrating immune cells should covering the more than 5% of the tumor area. This was the prerequisite for the atezolizumab. Next, please. So the title of the talk was how to choose the immunotherapy in the urothelial cancer. So generally we give the first line therapy in advanced cancer is a chemotherapy doublet with the platinum, or maybe without platinum is carboplatin. Then after 4 to 6 cycle, which we used to do earlier, we give the patient to 6 cycle. Then patient is having good response, then we leave the patient. And if the patient has disease progression after some period of time, maybe few months, then we initiate a second line therapy. So this was a wait and watch policy till the patient again have the disease, and we will give the chemotherapy. So this is one approach. Now the second approach maybe in this era will be chemotherapy plus IO combination. Then you stop the chemotherapy and give the continuous maintenance of IO, and then initiate second line chemotherapy if the patient progresses. But later on we see which is the best strategy. One strategy is first line chemotherapy, have the response CR/PR or stable disease. Then you stop the chemotherapy maybe after 4 to 6 cycle, and then start the IO maintenance, and you give the IO maintenance till the disease progress, and then you give the second line chemotherapy. So if you can measure these arrows, the arrow which is lasted longer is the second line switch maintenance strategy. Next, please. This is again the same thing, maybe repeated, like 50 to 80% patient achieve disease control with the first line platinum chemotherapy. This is very true because they are chemosensitive tumors, but OS is limited by the chemotherapy resistance. After this response is not durable, after some time patient will get the disease recurrence. So cisplatin based chemotherapy median OS is generally 14 to 15 months, and if you go carboplatin, it is 13 to 14 months. And some data are suggestive that carboplatin is little bit inferior than the cisplatin. Next, please. So what we can do, one strategy was that, other strategy was CT chemotherapy plus IO. If you have a response, then continue, stop the chemotherapy, give the IO, and if disease progresses, then you stop IO also and give the second line therapy. So for this strategy, 3 trial has been done in the world: IMvigor 130 and Keynote 361 and Danube trial. So all three trials have no difference if you give the IO maintenance and IO upfront. So there is no use of giving this CT-IO and IO combination. Next, please. Now the best strategy. What is that? You give the first line chemotherapy. 50 to 80% patient will achieve disease control with platinum-based chemotherapy. Either they will have stable disease, CR or PR. If patient having this kind of response, means other than progressive disease, you will start, or you may start, the avelumab maintenance, for which we have data. Avelumab maintenance therapy can improve outcome in patient who had received first-line platinum-based chemotherapy for advanced cancer. So, however, most patients progress within 9 months of platinum-based chemotherapy, but if you give avelumab maintenance, their progression may be delayed. So this is the timeline. First-line chemotherapy. If patient has CR/PR stable disease, you switch to the IO maintenance avelumab, and then progress, and then you give second-line chemotherapy. Next, please. So this is again repetition of that. It shows this switch IO maintenance is the best therapy, best way to give the treatment for the UC patient. Next, please. So what is the evidence for that? Javelin Bladder 100 trial. Javelin 101 was for kidney cancer, and it is 100 is for the urothelial cancer. So they have taken, this is a phase 3 randomized open label study. Unresectable, locally advanced or metastatic urothelial cancer with measurable stage 4 disease. Received standard first-line therapy 4 to 6 cycle, maybe cisplatin gemcitabine or carboplatin gemcitabine. If patient has a response, then you can wait for 4 to 10 weeks before the randomization and do the radiological assessment. CR/PR-SD patient will be had included. The N number, odd number was 700. Out of them, almost 50% patient was a PD-L1 positive, 51% patient. Then they randomized to two arms, avelumab plus best supportive care and best supportive care only. Avelumab was given 10 mg per kg, Q2 weekly, means every fortnightly you need to give. Then the patient were analyzed. The primary endpoint was overall survival, and secondary endpoint was PFS, overall response rate, time to response, response duration, disease control and safety, and the PROs. So next, please. This is a demographic pattern which is very pictorial. Median age was 68 years, gender 76% were the male, 24 were the female. This is the normal gender distribution of this cancer. ECOG PS was 0 in 61% of patient. Almost 40% patient had the PS1. Location of mets, 45% patient had non-visceral mets and 55% had the visceral mets. And the 52% get this gemcitabine cisplatin as a first-line chemotherapy. 42% patient gemcitabine carboplatin, and sometimes the 6% patient cisplatin switch over to the carboplatin during the treatment. Next, please. So now you see the overall survival in the total population and PFS in the overall population. So if you include PD-L1 positive and PD-L1 negative, in the both setting, you can see the overall survival is better in the avelumab plus best supportive care arm as compared to the placebo arm. So it was 23.8 months in the avelumab arm rather than 15 months in the best supportive care arm. And the p-value was highly significant, 0.003. And hazard ratio was 0.76. That means 24% patient had risk reduction of the death. And you see, like at the time point of the 24 month, 49, almost 50% patient were live in the avelumab arm. And in the contrast, almost 39% patient had live in the placebo arm. At the time point of 36 months, 36% patient were live in the avelumab arm rather than 30% patient in the you can see in the placebo arm. So every time point, this avelumab was better. And you see the graph has separated very early, and the separation was almost consistent with the almost see the 48 months, like 4 years. You see PFS in overall population. Overall means PD-L1 positive and negative both. So you can see PFS was avelumab is better, 5.5 months, and best supportive 2.1 month, almost double or 2.5 times better. And the two-sided p-value was 0.001. So it is highly significant. Next, please. Next slide. So this is the you can see the safety profile of the side effects of the avelumab as compared to the best supportive care. So they have the immune-related side effect like fatigue, pruritus, urinary infections, diarrhea, arthralgia, asthenia, constipation. We know, like nowadays this is very common because everyone is giving immunotherapy, but they can be very well taken care of. So nothing to worry, no serious side effect. And grade 5 side effect was very, very minimal. Almost 1 or 2 patients were died. Next, please. So OS or PFS benefit avelumab seen irrespective of the best response to CT. Patient had CR after the 4 or 6 cycle of the platinum doublet. They also responded well, or it was better than the best supportive care. If patient had PR, they also better in the avelumab arm. If patient has stable disease, it is also better. So it doesn't depend like how the patient responded. Except the progressive disease, patient will respond to the avelumab. Next, please. And this is OS was prolonged with avelumab in first-line maintenance plus best supportive care versus best supportive care alone, irrespective of the number of cycles. If patient had received 4 cycles and you have started avelumab maintenance, they have responded well. If patient has completed 5 cycles, still the graph is above the best supportive care line. And if patient has done 6 cycles and you have started maintenance, it is better in the avelumab arm. So there is no difference whether the patient has received 4 cycles, 5 cycles, or 6 cycles. Patient should have response like PR, CR, or stable disease. then they will get the response with avelumab. Next, please. Next slide. So subgroup analysis, because large population of this trial, Javelin 100, Asian population were involved. Almost 21% patient was in the Asian subgroup patient. So the results were almost same. There was no difference in the Asian versus the Caucasian. The same thing you can see, and primary endpoint was OS. If you analyze with this data set, the results are we will see again further. Next, please. So you see the first line, you give avelumab maintenance. It can prolong the survival as compared to best supportive care. So in avelumab arm, in the Asian population, it was 25.3 months, and here it was 18.7 months. So almost you can see like 7 month advantage in the survival. And if you go by the PDL1 population, median OS was still higher. In the avelumab arm, it was 26.1 month, and base supportive care arm, it was 19.4 months. So almost 7 or 8 months better. Next, please. Guideline update. Every guideline you will go for NCCN, ESMO or ESCO guidelines. Everywhere it is recommended that you give cisplatin eligible patient, you give the GEMCIS, maybe 4 or 6 cycle, then followed by avelumab maintenance, category 1 indication. You start DDMVEC, category 1, and then avelumab maintenance, it is also category 1. If you go by ESMO guideline, it is cisplatin based chemotherapy, then avelumab maintenance. So every guideline has suggested like it should be used as a maintenance. Avelumab maintenance is recommended in all platinum eligible patient irrespective of the PDL1 status. Whether they are positive or negative doesn't matter. You go with the avelumab maintenance. Next, please. So subsequent therapies after IU and post-platinum therapy. So there are some suggestion or data are available. Not very strong data with these newer drugs, but data are available for the post-IO progression. What you will give in the second line therapy. So enfortumab vedotin is the option. Gem carbo, maybe you can re-challenge if patient had responded well in the earlier side. A preferred regimen for cisplatin eligible patient is GEMCIS or DDMVEC with growth factor support. Some other regimens are there: edrafitinib, Pecli single agent, or docetaxel single agent, or gemcitabine single agent. So it can be used, or sometimes if patient is very fit, then you can use IFOS, doxa, and gemcitabine. Second line systemic therapy for locally advanced metastatic disease, post-platinum or other chemotherapy. You can use Pembro as a category 1 post-platinum. So if you have used avelumab, you can go for the stage 4 disease, pembrolizumab also. Sometimes other checkpoint inhibitor, Nivo or edrafitinib or enfortumab vedotin. So if something has not been used in the earlier line, or there was a good response in the first line, you can again re-challenge with a single or double agent. Next, please. So there is a summary of the trial. Summary of treatment sequencing in the avelumab arm of Javelin Bladder 100. Randomized to avelumab plus best supportive care 350 patient. A patient is receiving avelumab plus best supportive care, still means like after the data analysis, it is 43%, 43 people are taking. Discontinued avelumab and best supportive care 307. No second line treatment were reported to almost 122 patients. There may be PS is low or something, so they haven't received. You can see the second line treatment. This is very well consistent with earlier data also. Almost 35% patient are only the patient which will get the second line therapy. So you receive the second line, you give the second line treatment, and they have given like 185 patient have received second line treatment. Some have received re-challenge with the platinum based chemotherapy, 75%, 70% patient, 75 patient. Number is 75. PDL1 or PDL1 inhibitor, Pembro, Atijo, or Nivo. So they have also received in the 11 patient, and other 99% patient had vinflunin, single agent paclitaxel, gemcitabine, docetaxel, and this pemigatinib and edrafitinib. So generally in trial setting, we also would like to know, like after this giving experimental drug, what they have given to the second line treatment. So they have very well mentioned, patient can go for the platinum based doublet. If they have response, patient can go for the immune checkpoint inhibitor, and patient can go for the other single agent cytotoxic chemotherapy. Next, please. So OVAS in the avelumab arm by type of the second line treatment. So if you give second line treatment to the avelumab arm, there is almost no difference whether you give or not. Second line treatment will work better. Next, please. So this is the trial where enfortumab vedotin versus chemotherapy was tested in the phase 3 trial. This was the previously treated advanced urothelial cancer. So you can see if you have tried this enfortumab vedotin as compared to the chemotherapy, it fares better. And the difference in the PFS was 5.5 month versus 3.7 month, and the p-value was significant, 0.001. CRPR we generally don't expect, but still they have 6.9% patient at CR, and overall response at 41%, which is very impressive. We have used chemotherapy in first line, then avelumab maintenance, then second line chemotherapy versus enfortumab, and if still patient is having 41% this response, that means the drug is effective. Next, please. And this is the pivotal phase 2 adrafitinib study, updated PFS and OS. If you give adrafitinib, then you can see the patient may survive, 50% patient may survive 3 to 6 months, no, 6 to 9 months in between. So this is a 50% line. So the survival is little bit same, 5.5, 5.7 or 5.5 months. Next, please. And this is the studies for the using after avelumab second line therapy, pembrolizumab versus paclitaxel or docetaxel, physician choice treatment, or and you have seen in the earlier also this pembro works better in the second line immune checkpoint inhibitor. Next, please. So again, the thing is, just 1 minute. So if you give first line chemotherapy and give the treatment-free interval, and then you give avelumab maintenance, the total survival is approaching to 30 months, and with other strategies it is 16 to 18 months, 16 months, 12 months, or 15.1 month. So best strategy is give avelumab maintenance. Next, please. Next. So this is the last slide, summary slide. So long-term follow-up from the Javelin Bladder 100 trial, more than 2 years in all patients, continues to show prolonged median OS and PFS with avelumab first-line maintenance with best supportive care or without. Primary endpoint in overall population, median OS was 23.8 months in avelumab arm versus the 15 months in the best supportive care arm. OS rates at 2 years was 49.8 months and PFS was 23.4 months. OS was prolonged with avelumab first-line maintenance despite of the high proportion of patient treated with the best supportive care. And safety, and we know like avelumab maintenance is safe, and generally there are very, very less side effect, and we can deal with it. Next, please. So thank you very much. Thank you, Dr. Tarachand and Merck team for choosing me as a speaker. Thank you very much. And it was a nice learning. Thank you.
Thank you, sir. Thank you so much. And now I would like to invite Dr. Tarachand to give the concluding remarks. Over to you, sir.
And now this was a wonderful session, and which was just most important contribution from all the speaker, moderators, and the panelists who did a hard work and for making this session very fruitful. Yes, in today's session, this summarized all the GI with all the recent updates and the genetic urinary cancer also. And so I also thanks to the pharma which sponsored the session today, AstraZeneca and Merck also, and other pharma which have sponsored our this meeting, and these are the Pfizer and Mylan, FK and Novartis, Zydus and Mankind, Cipla and Reddy. So, and now I also thanks to the event organizing team Horizon, especially Geetika and Akta Mathur. So thank you all. Good night.
Thank you, sir. So